tahu, umur warga emas mulai pada umur 65 tahun ke atas. Jadi sebagai seorang pelajar dan sebagai seorang anak, saya harap anda lebih mengutamakan penjagaan warga emas daripada kalangan sama ada daripada ibu bapa ataupun keluarga ataupun rakan.
As for my experience posting in the geriatric ward, it really opened up my mind and my soul to take care of these special people with their special needs. So I hope that all of the older people out there to live their life more meaningfully and hope that they will live their life with no regrets. Love you all.
Hi all, my name is Leiting. I'm the patient family, the daughter. My dad was admitted in the PPUM for almost 1 month. Here, I would like to thank all the doctor and the nurse to take care of him. So now he's recovered and he can be discharged in 1 or 2 days time. So I know it's hard to take care of all the old people, also including myself. So I hope all have a happy elderly days.
Hai, saya Tigor. Saya bekerja di Ward 13U kurang lebih 5 tahun. Di sini saya melihat dan memperhatikan bagaimana cara merawat warga emas begitu suka daripada cara merawat pesakit biasa.
Assalamualaikum, saya PBK Hidayah dan Buat Jerry. Saya sentiasa dikelilingi oleh warga emas. Oleh itu, saya berharap kesemua warga emas yang saya sayangi berada dalam keadaan sihat dan sejahtera.
Hai, Assalamualaikum dan selamat sejahtera. Saya Jururawat Nurul Fatih binti Ahmad. Saya telah berkhidmat di ward geriatric selama hampir 10 tahun. Jadi sebenarnya sambutan Hari Warga Emas Sedunia pada tahun ini, saya berharap warga emas yang berada di Malaysia maupun di seluruh dunia menuju ke arah penuaan yang sihat, sama seperti populasi warga emas yang semakin lama semakin meningkat.
Bagi saya, warga emas adalah untuk dihargai. Pengorbanan dan titik perlu mereka tidak boleh dilupakan. Tanpa mereka, siapalah kita, dan mungkin kita tidak akan berada di sini.
Hargailah warga emas kita, ibu bapa, nenek-nenek atau opa, supaya mereka dapat hidup dengan sempurna sepanjang kita bersama-sama mereka. Luangkanlah masa bersama mereka serta sempurnakanlah kegembiraan. Jagalah kebajikan mereka kerana ingat satu hari nanti kita juga akan jadi warga emas seperti mereka.
Hello everybody, I'm Terence, I'm a geriatrician. My hope for this year's International Day for Older Person is that every older person feels valued, feels included, and will always be part of everything that we do. They're a group that needs us to care and to look after. Let's not forget that. So happy International Day of Older Person. Take care.
Selamat Hari Warga Emas Sedunia, dan saya berharap that semua dari kita, terutama sekali generasi muda, dapat menghargai semua kita punya warga emas di Malaysia dan seluruh dunia, kerana tanpa mereka tiadalah kita, tiada dulu, tiada yang lalu.
Hi, happy International Day of Older Person. We hope you love them as much as we do.
Wishing everyone Selamat Hari Warga Emas Sedunia. We should always love, cherish our old people and take a good care of them. Thank you.
Walaupun berusia, namun warga emas perlu dihargai.
Kekuatan fizikal dan mental harus kuat seiring dengan umur. Selamat Hari Warga Emas Sedunia.
A happy International Older Persons Day.
Selamat Hari Warga Emas 2023.
Healthy aging process.
Selamat Hari Warga Emas kepada seluruh warga emas di Malaysia. Selamat Hari Warga Emas.
Selamat menyambut Hari Warga Emas Sedunia.
Selamat menyambut Hari Warga Emas Sedunia.
Selamat Hari Warga Emas Sedunia.
Happy International Day for Older Person.
Jadi dengan itu saya mengucapkan Selamat Hari Warga Emas Sedunia.
A very good morning and welcome to our webinar. I'm Erin, Geriatrics Fellow, and it gives me great pleasure to be the moderator of today's webinar. Our webinar today is in conjunction with the International Day of Older Persons celebration this month and has been organized with lots of effort and thought by the organizers and panel of speakers. The theme this year is Aging with Dignity, the importance of strengthening care and support systems for older persons worldwide. It highlights the importance of protecting the welfare of both caregivers and care recipients, advocating for person-centered care that honors the dignity, beliefs, needs, and privacy of older individuals while affirming their right to make decisions about their care and quality of life. As we have a jam-packed webinar with a wide variety of topics related to care of older persons, there will not be any Q&A session. Nevertheless, I assure you there will be plenty of informative knowledge to gain from our esteemed speakers. To start off our webinar, it gives me great privilege to introduce and invite Professor Dr. Chin Ivern, who's next to me for the opening speech, followed by his presentation of the first topic of the webinar on mild cognitive impairment. Professor Dr. Chin Ivern is a senior consultant geriatrician and current head of geriatric medicine in University of Malaya Medical Centre. He trained in Dublin, Ireland, where he served as the lead clinical and research fellow at Mercer's Institute for Research in Aging and was a lecturer in gerontology at Trinity College. He holds a doctorate in medicine from Trinity College and is a fellow of the Royal College of Physicians in Edinburgh. Professor Chin is a founding member of the Aging and Age-Associated Disorders Research Group at University Malaya and the Malaysian Society of Geriatric Medicine. His expertise is in cognitive impairment, dementia, and elderly care, and has contributed greatly in advancing clinical services, research, and education in geriatric medicine in Malaysia. Professor Chin, the floor is yours.
Thank you very much, Dr. Erin, for that very kind introduction. I'd like to say a very good morning to everyone here and to those joining us online. It's a great pleasure to welcome everyone to this online webinar. I think this is our 5th year, and this is part of our celebrations for the International Day of Older Persons. As Dr. Erin has said, the theme this year for the United Nations International Day of Older Persons is Aging with Dignity. And I think I'm sure you'll find that the topics chosen for this webinar will be informative and will help enhance the care of older persons. This year is also a very special year for our unit. The Geriatric Medicine Unit in University Malaya Medical Centre is the first geriatrics unit and the birthplace of geriatric medicine in Malaysia. We have a very dedicated team of nurses, doctors, and allied health professionals, and we look after over 1,000 patients with complex problems who need holistic care each year at this unit. In addition, we provide a foundation for research and teaching for multiple disciplines at both undergraduate and postgraduate level. This year is our 25th anniversary, and I would like to thank everyone here for celebrating this anniversary with us. We will be having more events this Friday at UMMC, and everyone is welcome to join us in our celebrations. I would like to take this opportunity to thank each and every one of our organizing committee, led very efficiently by Professor Tan Kitman, Sister Nadia, Sister Losha, Puan Fazila, and Puan Hazlizan, as well as each and every one of our speakers today. I would also like to thank Professor Nazira, our UMMC director, as well as Professor Young Farida, our Dean of Medicine, for their unwavering support for geriatric medicine in University Malaya. As a unit, we hope to continue to promote the development of geriatric medicine in Malaysia for many years to come and to maintain the dignity of all Malaysians as we age. Thank you again for being with us for this webinar today and for continuing to be on this journey with us together. God bless. Thank you.
So we'll begin our first topic of the day by Professor Dr. Chin regarding mild cognitive impairment. Professor Chin.
Thank you, Dr. Erin. In terms of this topic, we we chose this topic because it's a very important topic as such, and it's a very common problem. So what I'd like to do is perhaps discuss as to what mild cognitive impairment is, talk a little bit about the prevalence, how common it is, what the risk factors, go through how we diagnose mild cognitive impairment, how we manage, and perhaps some of the future treatments that may be available as such. So what is mild cognitive impairment? Well, essentially when you think that something is wrong, that something's not quite right with usually the memory or your thinking processes itself, and this is something that is noticed by other people interacting with you, then you may have mild cognitive impairment if this doesn't interfere with what you do on a daily basis. So mild cognitive impairment is a situation where you have a slight, but it's a noticeable decline in terms of your thinking processes. And it's noticeable by yourself and others, but doesn't affect what you do as such. So what are the signs and symptoms of mild cognitive impairment as such? Now, usually mild cognitive impairment affects the memory as such, but it can affect other domains of cognitive impairment, the ability to reason, to think, to make decisions. And as such, someone with mild cognitive impairment may experience some or all of the following memory and thinking processes. Problems like memory loss, for example, difficulty remembering important information that he or she had no trouble recalling previously. Things like appointments, things like recent happenings, events, or even conversations. And occasionally the person may repeat the same questions after they've been answered, or they may tell the same stories over and over again. Patients may also show or have language problems. They may have difficulty finding words during conversation or when they are writing. They may have also difficulty in terms of understanding speech that's more complex than usual as such. There may also be difficulty with attention, loss of focus. Patients with mild cognitive impairment may be easily distracted. So a task that was once simple, easy, as preparing a new dish or following instructions may now take longer or become more challenging as such. And patients with mild cognitive impairment may have a loss of train of thought, perhaps in mid-sentence or mid-conversation. They may also have problems with reasoning and judgment, where complex problem solving, planning, and decision-making may be more difficult, more challenging for these patients as such. So if you compare mild cognitive impairment, dementia, and normal aging itself, in terms of mild cognitive impairment, you have occasional memory lapses as such. It's like difficulty concentrating or focusing, and you may have more frequent, perhaps more severe memory slips, concentrating, comprehension, and again, you may have also word-finding difficulties, but you have no problems completing tasks that are familiar, such as cooking a simple dish, finding your way home, or looking after yourself. And mood, behavior, and personality changes are not so apparent as such. So how common is mild cognitive impairment? Well, actually, mild cognitive impairment is thought to be about 3 times more common than dementia. And the global prevalence, that means the worldwide prevalence, is estimated to be about 12 to 18% in people over the age of 60 and above. And the prevalence increases with age. So at the age group of 60 to 64, the prevalence is nearly 7%, and it goes up to over 25% in the age group 80 to 84. So what happens in mild cognitive impairment? Well, mild cognitive impairment doesn't mean that you automatically get dementia later on, and it's not always the pre-stage of dementia. So roughly about 1 in 3 people with mild cognitive impairment will develop dementia within 5 years, especially if the underlying reason is a condition like Alzheimer's disease. Around 1 in 3 will not experience further cognitive or memory decline, and the remaining third may improve their conditioning their condition when the underlying cause of mild cognitive impairment is addressed. Now, individuals with mild cognitive impairment who revert to normal, who become better, however, do remain at higher risk of progression back to mild cognitive impairment or dementia compared to those who were never diagnosed with mild cognitive impairment. And the factors associated with a greater risk of progression to dementia include your age. The older you are, the higher your risk is. The type of mild cognitive impairment, if you have an amnestic or if it's to do mainly with memory as such. If you have more significant function impairment, if the neuropsychiatric symptoms are present at the time of diagnosis, if your scores are a bit lower, if you have a gene called ApoE4, and if you have abnormalities on your brain scanning as such. How do we diagnose mild cognitive impairment? Well, it's a clinical diagnosis at the moment where we use clinical criteria. The one that is most commonly used at the moment is the NIA-AA criteria and the DSM-5 criteria. There are new changes proposed which may come in this year or next year, and things may change in terms of how we look at mild cognitive impairment and its diagnosis. So if you look at the NIA-AA criteria, again, the core clinical criteria for the diagnosis of mild cognitive impairment due to Alzheimer's disease is a concern regarding a change in cognition. If there is an impairment in one or more cognitive domains, if independence is preserved in terms of functional abilities, and there is no dementia in the background. If you look at the DSM-5 criteria, the DSM-5 came out in 2013. As such, again, it's very similar to the NIA-AA criteria, where you need evidence of a modest cognitive decline from a previous level of performance. The cognitive deficits are not sufficient to interfere with independence in activities of daily living, and they do not exclusively occur in the context of a condition like delirium, and they're not attributable to another mental disorder. Now, there are some additions in terms of diagnosis of mild cognitive impairment as such. This was from the first key symposium in 2004, and you might hear your doctor saying amnestic, non-amnestic, single domain, multiple domain, and underlying etiology. It just means amnestic is mostly to do with your memory. Single domain, that means there's only one cognitive domain involved. Multiple domains means that there are more than one, and the underlying etiology is what is suspected to be causing the problem in the first place. In terms of steps to a diagnosis, diagnosis of mild cognitive impairment requires careful and comprehensive evaluation, and it consists of a complete medical history, a physical examination, neuropsychiatric assessment, and investigations, including blood, brain imaging, and perhaps other appropriate investigations as such. And very often, patients may require assessments to determine what happens and what the progression of the mild cognitive impairment is. In terms of a comprehensive history, there are some things that we are very interested in. It's how the complaint presents itself, how it starts, how it changes, what kind of cognitive domains are affected. We are interested in family history, the medications that are used, the mood, the sleep, and of course the function. Function is extremely important because, again, in mild cognitive impairment, we need to determine that there should be no functional change or only mild functional change that can be compensated for. If there is functional change that is more significant, then the patient has dementia, not mild cognitive impairment as such. In terms of physical examination, we focus often on identifying conditions that may affect your cognition, things like sensory impairment, emotional disorders, whether they are metabolic or endocrine disorders, nutritional deficiencies. We look for evidence of infections, substance abuse, or malignancy as well. In addition, we are interested in comorbidities, things like cardiovascular, respiratory, or diabetes. And we also do a full neurological examination, looking for focal signs as well as specific signs of neurodegenerative disease and other dementias as such. We also do an objective assessment of functional ability. Now, the neuropsychiatric assessment is an assessment looking for cognitive domains that are affected, and the cognitive tests are expected to be 1.5 standard deviations below what is expected for the patient's age and education. And there are different neuropsychiatric assessments that can be done. In terms of investigations, like I said, we do blood investigations, neuroimaging, and other investigations. In the future, we hope to be doing some biomarkers to look for specific illnesses that cause mild cognitive impairment. In terms of management of mild cognitive impairment, the aim really is to diagnose as early as possible. So if you have any worries or any concerns regarding yourself or somebody else, the important thing is to get the patient assessed, the person assessed, and diagnosed as early as possible. And what we want to try and do is reduce risk of progression to dementia, or at least delay the rate of progression to dementia as such. So the key strategy is to address risk factors for progression. It has to be patient-centered because no patient is the same. So individualized, patient-centered, and the approach is holistic. That means we don't only look at the physical aspect of the patient, but we also look at the emotional and the other cognitive and social aspects of the patients. So what we again want to try and do is, if you look at the trajectory for cognitive decline from preclinical, that means you have no symptoms, to mild cognitive impairment where you have some symptoms but it's not affecting what you do, to dementia where you have symptoms that affect your function. Again, if there's no intervention, the trajectory tends to be ongoing and progressive to a dementing syndrome. But if you can have early diagnosis and treatment, then what you can do is you can perhaps halt the progression or delay progression as such. So looking at risk factors, there are some things that we can't do anything about. We can't do anything about age, of course, your gender, your family history, your family is who they are, and the presence of certain genetic elements as such. But we want to look at some potential modifiable or reversible risk factors. Things like chronic medical conditions, vascular risk factors, comorbid conditions, chronic diseases, psychiatric risk factors, metabolic or infectious causes, medications that may affect your thinking processes, and also specific conditions that may be amenable to intervention, things like obstructive sleep apnea and normal pressure hydrocephalus. So what we do then with a patient with a diagnosis of mild cognitive impairment is to treat any potential modifiable cause when identified. Again, things like obstructive sleep apnea and normal pressure hydrocephalus. So in obstructive sleep apnea, we advocate the use of CPAP machines. In normal pressure hydrocephalus, we advocate the insertion of a shunt. If you have a metabolic disease like a thyroid dysfunction, nutritional deficiencies, or mood disorders, we want to reverse this. We also want to address any sensory deficits such as visual or hearing impairments, because we know that this increases the risk of progression to dementia as such. We also address mood disorders like depression and anxiety, and we target interventions to reduce issues with gait and balance so that we can reduce the risk of falls and injuries to the brain as such. Very importantly, we review and minimize the use of medications that can affect cognition, things like benzodiazepines, sleeping tablets, for example, certain muscle relaxants, all these which can affect your thinking processes as such. We also want to optimize vascular risk protection and the management of comorbidities like hypertension, high blood pressure, diabetes, and high cholesterol. We advise modification of lifestyle factors, and this is extremely important. So things like regular exercise, at least 150 minutes a week of aerobic exercises, a diet that is healthy and balanced. We encourage patients to improve their social networks, to initiate cognitive stimulating activities, to reduce weight, stop smoking if they are, and to minimize the alcohol intake. Other considerations are also very important: the patient and caregiver education, so that you understand the condition, and that helps in terms of staying to intervention, for example, exercise and so on. We encourage patients to plan for the future, especially in terms of advanced care planning, so patients can determine the goals of care, and they can also consider the designation of medical and financial power of attorney, as well as advanced directives or living wills. We also help patients and caregivers to address possible hazardous circumstances, things like driving, financial safety. Not so important in Malaysia, but in certain countries like the United States, things like gun safety is important. And caregiver support and counseling is also extremely important, especially non-pharmacological strategies, and looking at the needs of caregivers as such. Because caregivers can experience significant anxiety about patients' conditions and can be very distressed, especially if they have conflicting emotions arising from the patient's condition. In terms of pharmaceutical treatments, EGB 761 is considered a supplement in Malaysia. It's a dry extract from the leaves of ginkgo biloba plant, and it is given orally 120 milligrams twice a day. EGB 761 is currently the only pharmacological agent recommended for the symptomatic treatment of mild cognitive impairment in different existing guidelines and consensus publications. The mechanism is uncertain at the moment, but it may reduce oxidative damage and also may increase cerebral blood flow. And we use it for certain conditions in terms of mild cognitive impairment as such. There are also future possible treatments, especially for Alzheimer's disease mild cognitive impairment. Lecanemab is a humanized IgG1 monoclonal antibody that received FDA approval for the use in early Alzheimer's disease, and at the moment is under trial for the use of Alzheimer's disease mild cognitive impairment. So in summary, mild cognitive impairment is a common problem that increases with age. It is a significant risk factor for dementia, but not everyone will develop dementia. Some stay the same, and others may revert back to normal as such. So it's important to get assessed if you're concerned, so that you can reduce your risk for progression to dementia. It may also be an indication of an underlying condition that needs medical care, such as obstructive sleep apnea or normal pressure hydrocephalus. And early diagnosis is really important. It's key for early intervention. Our management should be holistic and patient-centered to reduce the risk of progression to dementia. Thank you very much for listening to me.
Thank you very much, Professor Chin, for such a comprehensive talk on mild cognitive impairment. Definitely, early diagnosis allows timely intervention, and we have gained a lot from your lecture. Thank you very much, Professor Chin.
Thank you very much, Dr. Erin.
Oral health amongst older adults is a very important issue, but often overlooked. It gives me great pleasure to introduce our next speaker for today to share on the oral health assessment tool, Associate Professor Dr. Jacob John. Associate Professor Dr. Jacob John completed his dental training in 1994 and became a prosthodontist in 1997. In 2023, he earned a Master in Medical Education from University Malaya. Previously a lecturer at Tamil Nadu, Dr. MGR Medical University in India, and a dental officer in Malaysia's Ministry of Health. He joined the Faculty of Dentistry at University of Malaya in 2009. Prof. Dr. Jacob supervises students in various dental master's programs and is involved in undergraduate education. He is a life member of the Indian Prosthodontic Society and serves as Honorary Secretary of the Asian Academy of Prosthodontics. An active member of the International Association for Disability and Oral Health, he was recently awarded fellowship for his contributions to special care dentistry. As Clinical Director for Special Smiles at Special Olympics Malaysia, he provides oral health education and care for intellectually disabled individuals. Professor Dr. Jacob has over 50 peer-reviewed publications and is passionate about community outreach, earning the Jan Anderson Norinda Award in 2016 for his work and with special needs populations. He has also presented at numerous national and international conferences. Without further delay, I pass the floor to Professor Dr. Jacob.
Thank you and a very good morning to all the audience. I come before you representing the dental fraternity, and I will introduce a small tool that can be used by patients as well as carers. Now, as we go along, you will understand why I emphasize that carers can be part of the users of this assessment tool, and why it is important for them to be part of this. Now, let me start by saying, by emphasizing once again, I'm sure if all of you are very much aware of this, but we have to understand that where we are heading and why it is important that we take extra effort to understand the needs of the aging population and how we need to change our way of living to be able to accommodate the needs of our aging population. Now, we all know that improved public healthcare services have led to increase in life expectancy. If you look at the world's population, those aged 60 years and above will double from 12% in 2015 to 22% by 2050. And by 2050, almost 80% of these older adults will be living in low-income and middle-income countries like Malaysia. Most older adults have at least one chronic non-communicable disease. The prevalence of those having more than one non-communicable communicable disease, where you call it as multi-morbidity among older adults in the community, is ranging between 15.8% up to 83%. And this is higher in the older age group above the age of 75 years. Now, what is the impact of population aging? It increases the burden, as I mentioned earlier, it increases the burden of chronic disease, and the prevalence of multimorbidity increases. Now, what are the associated factors to this multimorbidity? It includes those who are from the group of oldest old, women, living alone, low educational level, living in rural regions, smokers, alcohol consumption, unscheduled use of health services, polypharmacy, and more, I would like to emphasize those with negative self-perception of health and physical inactivity. Significantly, it increases the health expenses as well. Now, the functional decline will lead to the need for short, medium, as well as long-term strategies for social support. And this is why I would like to emphasize on this small tool that can be used by anyone to identify what is the need and how to go about looking for a solution. So it calls for more active participation and the use of health services. So coming to my topic, oral health care. Now, why is it important? Now, all of us know that it reduces the gum disease and bad breath. It prevents tooth decay. But it may be surprise to many that can be a source of pneumonia. It can help prevent heart diseases as well as even reduce the risk of stroke. So that is why it is very important for us to be aware of the oral health as we grow older. And sometimes it's not just the person that is growing older, but the group of people who are in their vicinity, be it their family members, the caregivers, the support system that they are in, has also got to play a very important role in this. Now, I mentioned about how to identify the need for oral health referrals. So one way is for us to make our own self-assessment. Now, if you look at these questions, you should be able to assess whether you do need to be referred or not. First of all, we have to check whether we have our own, whether the person has their own teeth or they have an artificial teeth, okay? But more importantly, the next 5 questions will inform us whether we need to be referred or we need to go and see a dental specialist for some intervention. It includes whether I have pain in my mouth while chewing, whether I have lost any fillings in my mouth, or I have any dental visits for any particular reason. I need to have a dental visit for a particular reason. If you try to avoid laughing or smiling because of problems in your teeth, mouth, or dentures, that is also an indication that you may need some intervention. If you had an interrupted meals because of problems with your teeth, mouth, or dentures, as well as if you're having difficulty relaxing because of problems with your teeth, mouth, or dentures. So all these are indicators for one to realize that one has to seek the intervention by a dentist. Now, coming to a more pertinent area of where a community or a society can play a role is by using this oral health assessment tool, or shortly known as OHED. Now, I emphasize on this, and I will be talking more in detail about this, because invariably more and more people are as we age, become functionally dependent or become frail, and we are not able to assess ourselves, our needs. So that is when the network around us will play a major role in determining whether we need to have a dental examination or an intervention by a dentist. So I would like to emphasize that this is only a screening tool. So it is to advise us as to what we have to do, and it is not a treatment tool. It does not replace the need for a regular examination, and it covers the patient's current oral health status, including the factors that can contribute to the risk of oral disease and indicate the need for referral. So the person who is close to the individual can observe, can feel, and ask the individual about these factors. Now, most of the people who are independent or who needs reminding, supervision, or needs further in assistance, or will not take dentures out of them. These are people who we can assess at our homes. But those that I've shown here in the red probably will need more support from the dental professionals. Those include those who will not allow to open the mouth, those who move away their head when you try to assess, those who are grinding or chewing or refuse treatment, those who are aggressive or try to bite when you try to assess the oral cavity, those with excessive head movements or cannot swallow well or cannot rinse and spit. So these will need to be referred to a dentist from at the beginning. It's when you cannot use this tool to be assessing them. Now, what is this tool? If you look at this, I have made it more presentable because by having these pictures, one will be able to appreciate better what are we looking for. So I will go one by one. Okay, we have 8 structures that we are looking at, and it's all within the oral fraternity. The lips, the tongue, the gums, and the tissue, the saliva in the mouth, the natural teeth that is remaining. If there are not natural teeth, how is the denture condition, the oral cleanliness of the individual, and any expression of dental pain. We will go one by one with all these factors. Now looking at the lips. Now if the lips is looking smooth, pink or moist, then you just have to maintain the situation. You don't have to have a concern. However, if the lip looks dry, chapped or red at the corners, like what we see here in the picture, then you can do some interventions for the individual. You do not, at this stage, you may not need to take the patient to the dentist, but you can do your own simple interventions like keep the person hydrated, use lip balms or ointments as needed throughout the day, avoid licking, picking or biting on the person's lips, as well as you have a humidifier in the room where the individual is stationed. However, if there are swellings or lumps, white, red or ulcerated patches, bleeding, ulcerations in the corners of the mouth, then you do have to seek a professional advice. Now coming to the tongue, if it is normal, moist or pink, then again there is no issues, just maintain. But if the tongue, as shown in the picture, if it shows patches, it is fissured, red, coated, some interventions can be undertaken. You do not have to worry about getting the advice of a dentist at that point. You can just make sure that the oral hygiene, the tongue hygiene is maintained. You can use soft brush, nowadays you even have ultra soft brushes. You can use appropriate mouthwashes to keep the oral hygiene. Avoid spicy food, minimize salty as well as acidic drinks or acidic food. Sucking on the ice can also keep the tongue have a soothing effect, as well as rinsing the mouth with salt water. So these are all interventions that can be done in the home. However, if you see patches that are red or white or ulcerations and swellings as shown in the diagram, then you need to seek a professional advice. The third one is the gums and the tissues. If the gums and tissues are pink, moist, smooth or there are no bleeding in the gums, then it's just a matter of maintaining the situation. However, if you see that there is dryness or shiny, rough, red, swollen around the teeth, swollen gums around the teeth, one or more teeth, or you see an ulcer or a sore spot around the dentures, then you need to seek the professional advice. As well as if you see there is swollen bleeding around 7 or more teeth. If the person has more teeth, then the chances of more swellings will be there if the oral hygiene is not maintained. Then ulcers or white patches, generalized redness or tenderness, all these are indicators for the person to seek oral professional advice. The fourth one is the saliva. Now, if the saliva is moist, watery and free-flowing, then there is no reason for concern. However, if the saliva is dry, sticky, little saliva is present, or the individual himself or herself thinks that they have dry mouth, then some interventions can be done in the home. For example, you can get the person to sip non-carbonated sugar-free fluids. You can get them to chew gums that contain xylitol, or use carboxymethyl cellulose saliva substitutes as mouthwash. Avoid mouthwashes that contain alcohol. Don't wear the dentures during sleep, as well as breathing. Make them breathe through the nose. I'm not sure how easy it would be for you to make them change the habit, but that would also be one of the reasons. If they're breathing through the mouth, then the mouth while they're sleeping becomes dry, and that can be one of the reasons for the reduction in the saliva. These are things that can be done by the individuals or with the help of their caregivers. However, if the tissues are patched and red, very little or no saliva is present in the mouth, the saliva is thick or ropey, the individual also complains of dry mouth, then there is a need for us to seek the professional advice. Coming to the natural teeth, if there are no decays or broken teeth or roots in the mouth, then it is a matter of retaining whatever the person is undergoing. However, if you have 1 to 3 decayed or broken teeth, or you see some roots in the mouth, in the oral cavity, you have to seek the professional advice of professional care. More serious, if you have 4 or more decayed or broken teeth or roots, or the teeth are all very worn down, or with less of 4 teeth in the mouth, but the person does not have denture and finding it difficult to chew, then also you would need to seek the professional advice. Dentures. If the individual is wearing a denture, then that also has to be assessed, because you can have problems with dentures as well. Now, if the denture, there is no broken areas in the denture, the teeth of the dentures are all worn regularly. And if you see, this is something probably not very common among many denture wearers, but if you have them labeled, especially in abroad, it is mandatory for one to have it labeled. In Malaysia, it is recommended to label the denture. Now, why do we have this labeling system? Especially when the person is in a nursing home and there are many individuals with dentures in the home. They may not be able to clean their dentures on their own. The caregivers will be the ones who are doing the service, and in case they are not sure whose denture it, you will have issues of mismatch. Some dentures going to some wrong mouth. So this is why when you have the labeling on the denture, it makes it easier for us to identify whose denture it is. So if you have 1 or more broken areas or tooth on the denture, then only, and the person is only wearing it 1 or 2 hours in a day. And if you don't have labeling, proper labeling, and you there is a need for that, then you will have to seek for a professional help. More importantly, if there are more than 1 broken area or tooth dentures missing, or the dentures are not at all worn because of poor fit, or worn only with denture, lots of denture adhesive in being applied, then also the person needs to get professional advice. Now, why is it important? Now, we may think that one doesn't have any teeth and person can live comfortably. Now, the teeth is how we are able to chew our food. And if you're not able to chew our food well, we will try to accommodate the best way to replace the food that we are using. So the amount of nutrition that one receives will be modified, and it may not be suitable for the individual. So that is why it is very important that we have proper teeth at whichever age we are, so that teeth, whether it's natural teeth or artificial teeth, it can help in our mastication. So this is also another area that is very important. The one other area is the oral cleanliness. Now, if the oral cavity is clean, there are no food particles or tartar, as we call it, in the mouth or in the denture, then it is just to maintain the condition. However, if there are food particles, tartar or plaque in 1 or 2 areas of the mouth, or on small areas of the denture, or the person has got bad breath, then there needs to be some reinforcement that can be done at the home, within the fraternity of the home, by improving the brushing technique and also the oral hygiene of the individual. However, if the food particles start in most of the areas of the mouth, as shown in the diagram, and the person is also having severe halitosis, then we need to get the person examined by a dentist, and probably need more oral hygiene instructions being provided. Finally, talk about the dental pain. Now, the dental pain is something that probably we can ask the individual whether they have the pain, or sometimes we may have to look at the facial expression to identify whether their person is suffering from any dental pain. Now, if there are no behavioral, verbal, or physical signs of pain, no issues, you can just maintain as it is. If you see verbal or behavioral signs of pain, such as pulling of the face, chewing the lips, not eating, not trying to avoid eating, or being aggressive when being told to eat, then probably the person is suffering from dental pain and not able to explain it to the carer, and we have to take the responsibility of seeking the professional advice. If the physical signs such as swelling or cheek or gum broken teeth, ulcers or gum boils are visible, as well as there are verbal or behavioral signs of pain, also it is important that we seek for dental help. So that's about the oral health OHAT that I had explained, and now I hope you will be able to appreciate that anybody can be able to do the assessment and do the triaging, whether it is to maintain the condition as it is or need to do some intervention that can be done at the home by themselves, or they need to seek a dental or professional help to improve the condition. Now, I would like to once again re-emphasize on this important factor, the social isolation. Now, it is said that 20% of older person population lives alone in the community. Okay, this is quite recent by the United Nations, and because of this, there is the potential higher risk for social isolation of the adults in the community. And long-term deprivation of these relationships can lead to problems in social civic engagements and a lack of participation in social activities, eventually leading to social exclusion. Study done in Japan, a big study done in Japan, has proven that prevalence of social isolation has increased a substantial amount post-COVID. Okay, so this is also an area that we have to take into consideration as our population aging is increasing. So because it has a considerable burden on the national economy also. With that, I thank you all, and once again I would like to emphasize on leaving no tooth behind in an aging world. Thank you.
Thank you very much, Professor Jacob, for sharing with us such important topic of oral health, how we can assess in such a detailed and informative way, when do we maintain, and also when do we need to seek professional help. Thank you, Professor Jacob.
Thank you.
Our next topic is related to COVID-19 infection, and we have Associate Professor Dr. Tan Kit Man to share with us the prevention and treatment for COVID-19 after transitioning from pandemic to endemic. Associate Professor Dr. Tan Kit Man is a senior consultant geriatrician with the Geriatric Medicine Unit in UMMC. Professor Dr. Tan Kit Man is very active in education and research, and her special interests include stroke, atrial fibrillation, dementia, osteoporosis, hypertension in older persons, and comprehensive geriatric assessment of the complex older person. Professor Tan, the floor is yours.
Okay. Good morning, everybody. Thank you very much for joining us today to celebrate our International Day of Older Persons, and also to join us on our public awareness talks. And the title of my talk is Living with COVID-19 in an Endemic World, winning the race against COVID-19 with this international campaign called the Know, Plan and Go campaign. The first step of race preparation, if we want to win the race, is to have keen awareness of our surroundings. We think that the COVID-19 emergency and pandemic may be over, but in reality, these are the current cases of COVID-19 in Malaysia. We can see that about 3-4 months ago, after festivities, for example, Chinese New Year, Hari Raya, Deepavali, Christmas, there is a spike in cases. And then it gradually goes down. And we know that soon we will have another festivity coming up, which is Deepavali, then after that Christmas. In the middle of September, we still had about 400 over total new cases reported per week. But I'd like to remind you, the real cases are probably much, much more, because nowadays maybe people forgot to test, or they don't have a test kit anymore, or if they test positive, they just rest quietly at home and don't put it on MySejahtera anymore. So the real numbers are actually much higher than 400 over new cases per week. What about hospitalizations? In the same week, in mid-September, 191 people were hospitalized with COVID-19. But thank goodness, in the last 4 months or so, there were no deaths recorded. However, I must stress that in older people, after they had the COVID-19 and returned home or returned to their care home, they may have suffered so much complications from COVID-19 that they may actually have passed away later. And then it's not directly attributed to COVID-19, but the complications after hospitalization because they got so weak with the COVID-19. And this slide is a live slide from our KKM COVID-19 website. It says that data as of 12th of October, only 4 days ago. The active cases right now of COVID is 8,600. Home quarantine 8,500 and hospitalized 110. Again, I will stress that this may be much less than the true figures because many people may not test or report. Long COVID can happen after the infection is over. So if we say that, blood cell count have returned to normal and it looks like the infection is over, long COVID can happen at the end where there's prolonged fatigue, reduced attention and cognition, etc. How frequent is this or how common is this? Right now it's estimated that at least 65 million COVID-19 patients still suffer from long COVID after finishing the infection. And for people who are bad enough to be hospitalized, 5 to 7 out of 10 people hospitalized with COVID may have long COVID. And non-hospitalized patients, 1 to 3 out of 10 may have long COVID. So we should anticipate the challenges ahead and gain self-awareness. Please examine yourself and your family members. Are you at high risk of COVID-19? Who are at high risk? More than 20% of the world's population are considered high risk. They have a higher risk of severe disease and death. More than 65 years old, obese with BMI more than 30, heart disease, diabetes, which is fairly common in Malaysia, so is heart disease, any disability, any history of cancer, chronic lung disease or asthma or old tuberculosis, chronic liver disease, dementia and other mental health disorders, any disease affecting the immune function like rheumatoid arthritis, SLE, smokers including ex-smokers, so acting best thing is don't start at all, don't start smoking at all, or pregnant mums and those who have delivered a baby within the last 6 weeks, so new mummies who have delivered a baby in the 6 weeks ago. Age is actually the most important risk factor for COVID-19. The risk of entering intensive care unit, needing to use the breathing machines or the respirator, long hospital stay, and risk of death. So for someone aged 65 to 74, their risk of death is 6 times compared to the younger adults, and 75 years and above, 8.7 times than the younger adults. So older people also should be more vigilant after recovery from the infection itself. They are more susceptible to long COVID. 1 in 4 older persons will have long COVID, and 1 in 3 will require medical care related to their COVID infection. How about obesity? How does it affect the person if they catch COVID? So obesity is defined as BMI more than 30, or for those who are teenage years or adolescents, their BMI is more than 95th percentile of their peers. Why does obesity make a person more likely to get severe COVID? because the obesity may cause the body to be a potential inflammatory state with poor immune function, poor heart and lung function. The heart and lung are working against a very high body weight. The physique, the large body size also may affect the respiratory care when they later on, if they get severe COVID, admitted and need ICU care. Presence of chronic disease or other comorbidities, because with obesity there could be high blood pressure, heart disease, diabetes. So this will prolong the length of hospital stay and more severe cases in people who have obesity. And for those whose BMI are more than 35, the risk of intensive care admission is by 3.6 times. Risk of death and risk of long COVID also increase by 3 times. For people with diabetes and related complications, risk of severe disease increased by 43%, risk of death by 26%. Chronic kidney disease, severe disease 44%, risk of death 93%. Heart disease, severe disease 28%, risk of death 56%. And chronic lung disease, risk of severe disease by 36% and risk of death by 40%. And the total number of diseases also matters. If someone had 2 to 5 medical conditions compared to those with no medical conditions, their risk of death is 2.6 times. 6 to 10 medical conditions, 3.3 times, and more than 10 medical conditions, 3.8 times. So then let's warm up for the race start against COVID. We have to prepare ourselves. Before we catch COVID, we hope we never do or we don't, but we must prepare in case we do. What are the measures to be taken when COVID-19 strikes? So first of all, we have to reduce the risk of COVID-19 infection with good personal hygiene. We know that wearing a mask will help. It must cover the nose and the mouth, and the nasal bridge, the nose bridge piece must then go over the bridge of the nose tightly. And ideally, the mask goes under the chin, below the chin, cover nose and mouth completely. No point just covering the mouth and leaving the nose. Must change daily and discard after use. Hand hygiene, wash hands with soap, use alcohol gel for disinfection, and we maintain social distancing. Then, to prepare ourselves, we should then record our health status and what medications we are taking in advance. Maybe type it out on an A4 paper. These are my medical conditions, these are my medications. You can actually scan this QR code and it will bring you to the Malaysian No Plan Go website. And it will inform you after you answer a few simple questions whether you are at high risk. So you'll be advised to write down whether you have any special medical status, your daily prescription of medications, whether there was pregnancy recently, and any previous treatment with antiviral drugs. It can also, this website will help guide you confirm whether you are high-risk population for severe disease. Why is listing down all the medications important? We also have to inform the doctor whether we have kidney disease or liver disease and allergic to any drugs. It's because it can help the medical staff determine if you need an adjustment of your chronic medications before starting on COVID-19 treatment. There is actually an antiviral medication that can treat COVID-19. It's not an antibiotic. It's actually a special antiviral that treats specifically COVID-19 infection. And, even that medication, the dose may need to be adjusted according to your current medications. COVID-19 vaccination, when it becomes available again, if there's a latest booster vaccine, do take opportunity to take the vaccine, because the vaccine will decrease risk of getting COVID by 84%, risk of severe disease by 88%, risk of death by 68%, and risk of long COVID up to 41%. So it's worthwhile getting the booster dose when it becomes available. So let's meet the challenges head on then. We were trying to prevent COVID. Now, what if we have symptoms and then actually do develop COVID? We should take action immediately. Once we experience any of the suspected symptoms, we should get the RTK antigen test kit as soon as possible. And the symptoms could be a fever, headache, abnormal sense of smell, runny nose, shortness of breath, dry cough, sore throat, and muscle pain. But I must stress that older people or immunocompromised people may not have the classical or typical symptoms, the common symptoms we are talking about on the left. They may have more non-specific minor symptoms, like a very low-grade fever, but more seriously, they could have impaired consciousness, tiredness, well, tiredness also happens in younger people, diarrhea, loss of appetite, not eating and drinking, and decreased mobility. So in the older people, we have to be more vigilant because they may not have the classical symptoms we're talking about on the left. If the results are positive, high-risk population, so if you've determined that you've got any of the high-risk factors, seek medical attention promptly. And whether you are high risk or not, there are some warning signs of severe disease. Even some people are unlucky, they are not in high risk category, also they get very severe disease. Seek medical attention immediately when warning signs occur. Shortness of breath, persistent chest pain or chest tightness, reduced consciousness level, very lethargic, blue skin, lips or fingernails, unable to eat or drink or take medicine, no urine in the past day or significantly reduced urine volume, blood pressure less than 90, no fever but heart rate more than 100. That may be a sign that the person is close to collapse. And for children, we also have to pay attention to severe COVID-19 warning signs. So on the left, any child who's got COVID-19, we should seek medical attention as soon as possible if they have fever more than 48 hours, high fever more than 39 degrees Celsius with chills and cold sweat, persistent poor mobility after the fever has subsided, means they're very lethargic, they're unsteady, persistent shortness of breath or chest tightness, chest pain, vomiting, headache, abdominal pain, did not eat or pass urine for quite a few hours. Immediately seek medical attention if they have fits or seizures, it's called convulsions, impaired consciousness or persistent drowsiness, short of breath or their chest is really struggling to breathe, blue lips, oxygen level less than 94, the limbs feel very cold and mottled like net-like with cold sweats, body temperature more than 41 degrees, a myoclonus, which is jerking, uncontrolled jerking of muscles, and unsteady walking. So we have older persons in our home. There's also the normal age, the younger adults, and also then we have children. Everybody is at risk of severe disease. Then organ systems of children. If they develop severe disease, they may develop multi-organ failure and also something very serious called acute encephalitis, which is infection of the brain cells, and that can lead to brain damage. So we should seek medical attention and treatment within the 5 days of starting the symptoms. How do we do that? I'm going to show you some local websites later. The best thing is you find out from your local private hospitals which may stock the antiviral treatment that I'm talking about, and also from the clinic kesehatans. Because it's quite an expensive treatment, not every center will stock it. So you can get prepared by finding out. If this antiviral drug is given within 5 days of onset, it should be as early as possible. You don't wait until day 5, then only look for the medication. It reduces hospitalization risk by 80%, ICU or death by 46%, of ICU admission by 46%, death by 56%, and long COVID by 13%. And what are the long COVID symptoms I spoke about earlier? They can occur within 3 months after COVID-19 and last for more than 2 months and beyond. That would be considered long COVID. It will include heart, cardiovascular symptoms like chest pain, palpitations, bleeding, inflammation of the heart muscle, and clots in the veins called DVT or pulmonary embolism, even stroke. and it can affect the memory, tiredness, cause depression, anxiety, dizziness, ringing in the ears, abnormal sense of smell and taste, a shortness of breath and cough that lasts a bit longer, and then it can worsen diabetes and cause kidney or liver injury. For the reproductive system, it may cause worsening period pains and also erectile dysfunction and digestive system symptoms as well. So here are resources to update yourself with the latest information on COVID-19. Please take action immediately after getting COVID-19. This is the No Plan Go Malaysian website. Actually, No Plan Go is an international campaign, but it's also a localized Malaysian website. And there is the Ministry of Health COVID-19 website, where you can get up-to-date advice and information on the COVID-19 situation in Malaysia right now. There's also a hotline for every single state. There are multiple phone numbers that can be rung to get advice. But your nearest clinic kesihatan also is a good place to start. So in summary, there are 4 steps to prevent the epidemic from coming back. Again, we must maintain good hygiene habits, vaccinate when the vaccine becomes available. Whenever there's a symptom, you test upon symptom onset. And also to add on a little bit, sometimes the symptoms could be due to other viruses. So if in doubt, you go and see your local doctor. It could be influenza, RSV, but COVID-19 test kits we can purchase from the pharmacy. And then go and see your doctor. So for those with milder illness, they may benefit from the antiviral treatment at home. You can stay at home and take it. For those who are very sick, don't delay, don't stay at home. Go quickly to hospital, the emergency department. So do protect yourself from COVID-19. This No Plan Go campaign is worth checking out. And if you have any further questions, do talk to your local doctor about treatment options for COVID-19. Thank you very much.
About COVID-19, that we should not forget, although we have passed the pandemic phase, but it's still important to still screen actively ourselves and get early and timely treatment. Thank you, Professor Tan. Parkinson's disease is a degenerative brain disease that affects motor function and mobility and commonly affect older adults, affecting their independence. We are fortunate today to have Ms. Sarah Liu, who is the current president of the Malaysian Parkinson's Disease Association, to share with us more about the Malaysian Parkinson's Disease Association, MPDA. She has dedicated 29 years of service in improving the lives of persons with Parkinson's disease in the community and was awarded the World's Parkinson's Congress Robin A. Elliott Award for service to the community in 2019. With no further delay, I invite Ms. Sarah to give her talk.
Good morning, ladies and gentlemen. First of all, I would like to thank the organizer for inviting us today to share about our work as well as to create Parkinson's awareness. It has been 30 years since our association was founded, and our mission has always been to provide a space for people with Parkinson's and their families and find support, resources, and a sense of community they need. This journey is not just about the challenges, it is about resilience, connection, and hope. In the next 15 minutes or so, I will share with you how our group has evolved, the activities that we have undertaken, and the impact we have made on people living with Parkinson's. It is about the incredible power of coming together as a community. I'm going to discuss or share the topic under 5 categories. I would like to flip the last one, what is Parkinson's, to the top, and then I'm going to talk about who we are, what we do, how we do it, and our impact about Parkinson's, I'm going just to go very briefly. So Parkinson's is a chronic degenerative disorder of the central nervous system that affects both motor and non-motor symptoms. The motor symptoms are like stiffness, mobility problems, slowness, and tremors, and non-motor symptoms are like hallucination, constipation, anxiety, and lots more. It is the second most common neurodegenerative brain disease after Alzheimer's disease. It afflicts 1% of the population over the age of 65 and 3% over 80 years old. The risk factor is actually aging, although there are other things that come, that have been mentioned, like environmental, but still it is the risk factor. And sometimes PD occurs in younger people below the age of 50, and we call them people with young onset Parkinson's. It has a progression affects both the physical and mental aspect of life for people with Parkinson's, their family and communities. When someone is sick in the family, it always affects the family as well. And if the number is too big, it also the wider communities. According to the global worldwide statistic, about 8.5 million people are living with Parkinson's, and by 2040, it will increase to 12 million people. There is actually no statistic in Malaysia pertaining to the number of people afflicted with Parkinson's, but it is estimated that there are about 20,000, and by 2040, it will increase sixfold to 120,000. There is no known cause, and there is no cure for it, but it is treatable with medication. Who we are. So here's something about our association, the Malaysian Parkinson's Disease Association of Recorded MPDA. The association was formed on 12 September 1994 as the first Parkinson support group in Malaysia. It is located in Happy Garden, Old Klang Road, Kuala Lumpur. It is a tax-exempt, non-government and non-for-profit organization, and we are registered with the Registrar of Societies. Currently, it's run by 11 office bearers, comprising mostly people with Parkinson's and caregivers on a voluntary basis. I'm involved because my late father also had Parkinson's, so that's how I started serving the association 29 years ago. Our association is not funded by the government. We rely on the generosity of the public, individuals or companies. Our mission is to empower, educate, and improve the quality of life of people living with Parkinson's by fostering a community of understanding, resilience, and hope. And our vision is to create a supportive community where people with Parkinson's receive the support, care, and understanding to lead a fulfilling life, and a community that actively supports Parkinson's awareness, care, research, and a cure. Okay, what do we do? Why support groups matters? It matters because it offers emotional support, a safe space for people with Parkinson's to share experience and challenges. It reduces isolation, promote peer learning and social connection. In other words, they are not alone, and they get to meet other people at the association. And resource access, it connects members with healthcare professionals, therapies, and resources tailored to people with Parkinson's. At our association, we connect with healthcare professionals. They come over to have talks, and that is the opportunity for our members to meet them, to ask questions, and to learn more. Caregiver support. oftentimes we forget about the caregivers as well. But that is also a place where caregivers converge and they learn tools and guidance and a community to discuss their own challenges and strategies. Advocacy to promote awareness of Parkinson's. As a Parkinson's support group, we need to create more awareness of Parkinson's disease, and that is why I'm here today. It's also an opportunity for our association to connect with the wider community to partnership like with UMMC, and with the invite we are able to promote more about Parkinson's disease. And at the support group, we run activities and therapies, and I'm going to tell more about that in the next slides. So, how we do it? These are our past activities. I start by sharing the last activities that's held at our center. It is a Chronolox house in Old Klang Road. We have 2 premises there, and our members get to, listen to talks, and we have it held at the outside. You're at one with nature. We have the air cooler, we have the plants behind us, and it is, especially when it's post-pandemic, such place is such a welcome place for people to get together. And the last one we had was on the topic of hallucination and delusion by a clinical psychologist. And after that, we have healthcare art therapy, and you can see that our members, they were doing art, and after that, they paint the painting that they did on the tote bag. We were hanging on our gate, and I thought that if we put there a bit longer, someone might come to buy them. And that was the next one. Is also about sharing knowledge and understanding of Parkinson's. It's also about rehabilitation. So we also work with physiotherapists. They came over, they gave us talk, and the latest one also just last August, we have exercise and rehab, 2 stages of Parkinson's. And here is the slides. We have quite a good attendance. Yeah, here is a short slides about.
No pain, you can push yourself up, one knee up, the other knee up, yeah, and then come back up. So this is more for early stage lah. Right, middle stage and late stage is different already. Right, you probably need some assistance, you probably need to crawl to some support.
Okay, and the next one is about nutrition. As you know, Parkinson's treatment is a multidisciplinary approach, and in July we had a nutritionist from UCSI University, and she talked about eat well and stay well. And also we have also physiotherapists that came along and also taught our member some exercise. And here you can see our members. Actually, they were practicing their voice, and there was a speech therapist who came by and shared with them her knowledge on speech therapy. And Parkinson's is a movement disorder, and it's so important that you keep moving. So we do have an individual who volunteer at our Parkinson Center, and here we have our Dance for Parkinson's, and you see how happy they are dancing and moving. And this is a weekly activities. The earlier activities, usually we hold them on Tuesday, but we do have a weekly activities. This one is held every Thursday at our Parkinson Center, and where members come together and they dance the social dance. Here it
She walked through my mind, searching for
The gentleman in pink is actually over 80 years old, and he loves dancing, and it is so heartwarming to see our members moving in rhythm, in sync with the music. And this session is actually thought by an individual, KCO, on a voluntary basis for our members every week. And our association is not funded by the government, and the way to go for us is also, as I said earlier, through partnership and collaboration. And we work with UKM for the past 10 years. We work with UKM, where the students had internship at our center. And this is the speech therapy clinics, and I just show a sample to you. So it's good that our members, learn how the technique of speech improvement, and they don't have to go to the hospital. And when the student comes to the center, they are more inclined to come to our center and learn as much as they can to delay the onslaught of Parkinson's. And another collaboration on World Parkinson's Day, which falls on April 11 each year. And by the way, our symbol of Parkinson's is the red tulip. And this year, we work with Hospital UITM, workshops and Parkinson awareness. And besides having our members there, they also organize a workshop where they talk about Parkinson's and how about the management of Parkinson's. And as you can see on the bottom right slides, they also have physiotherapy to do exercises, and movement is so important in Parkinson's. And same with the hospital, Suba Medical Center. So they talk about Parkinson's Wellness Day. So our members were there, and they had fun having games and etc. And this is actually part of our fundraising for the past 25 years, and we work with the larger community. So every year, an annual charity jog walk and wheelathon was organized, and our organization is one of the participating organizations. So we went to Tataramatika and we did the walking. Yeah, you can do it. Some of our members actually went along. And just a little bit about the post-pandemic. Before the pandemic, our activities were mainly held at the Parkinson Center. But during the pandemic, we start, because of the usage of the Zoom, the online activities were shared with our friends across the sea, in East Malaysia, or our support, the other support group. We share our resources with them, and we also have this weekly Dance for Parkinson's. Actually, now it is fortnightly, and we share with our members from Penang and East Malaysia. So here goes. So this is a group of caregivers getting together to share experience while their loved ones are at the other corner doing other things. So we haven't forgotten the caregivers. So it's very important that they are also in good health and also able to learn from each other just as much as people with Parkinson's getting together to learn from each other as well. So this is one of our sessions where our members get together and share challenges and offer support to each other. So what is our impact as a Parkinson's support group? We help members to build coping skills, better informed and motivated. When they talk to each other, when they share experience, they inspire each other. and they have emotional resilience. They feel less isolated and more understanding of the condition. There is a sense of belonging. They feel that everybody is the same as they are at the center, so they don't feel so conscious, and they also help people who are in the same situation as they are. I always tell our members, they come to the center is not to seek help. Today they share their experience and they motivate others. Or I would say that today they come to seek information, to learn from the others, and one day they will in turn to share their experience and with others, and hence motivating them as well. So in other words, you can say to help others is to help yourself. And as a group, as a Parkinson's support group, we have a bigger voice to advocate for better healthcare and benefits for people with Parkinson's, but we also encourage for research to help improve quality of life and to find a cure. So looking ahead, the future of our support group, of course, we would like to expand our services to more people. We want to add programs for mental health and people with young onset Parkinson's, and even for Parkinson's plus. And sustainability, as I said earlier, we are not funded by the government, so we need fundraising, we need partnership to sustain, and also leadership succession. Not many people really want to work at the association because many prefer to go into the business world. So, and lastly, I would like to send a message of hope. No one needs to face Parkinson's alone. Together, we build a stronger community. Don't let Parkinson's stop you. And together, we conquered Parkinson's, and don't let Parkinson's define you. Thank you.
Thank you, Ms. Sarah, for such amazing sharing of the amazing work you do with the patients who live with Parkinson's, as well as their carers in the community. We hope to those out there who have listened in to our talk here today, continue to give the Malaysian Parkinson's Disease Association more support in any way. Thank you, Ms. Sarah. So we would like to take a break, a 10-minute short break for you to move about, have a quick cup of coffee before we resume with the second session today, and we will be back online at 10:40 a.m.
pelajar nursing tahun 3 Kuala Nursing Malaya. Seperti mana anda tahu, umur warga emas mulai pada umur 65 tahun ke atas. Jadi sebagai seorang pelajar dan sebagai seorang anak, saya harap anda lebih mengutamakan penjagaan warga emas daripada kalangan sama ada daripada ibu bapa ataupun keluarga ataupun rakan.
As for my experience posting in the geriatric ward, it really opened up my mind and my soul to take care of these special people with their special needs. So I hope that all of the older people out there to live their life more meaningfully and hope that they will live their life with no regrets. Love you all.
Hi all, my name is Leiting. I'm the patient family, the doctor. My dad was admitted in the PPUM for almost 1 month. Here, I would like to thank all the doctor and the nurse to take care of him. So now he's recovered and he can be discharged in 1 or 2 days time. So I know it's hard to take care of all the old people, also including myself. So I hope all have a happy elderly days.
Hai, saya Tigor. Saya bekerja di Ward 13U kurang lebih 5 tahun. Di sini saya melihat dan memperhatikan bagaimana cara merawat warga emas begitu suka daripada cara merawat pesakit biasa.
Assalamualaikum, saya PPK Hidayah dari Buat Jerry. Saya sentiasa dikelilingi oleh warga emas. Oleh itu saya berharap kesemua warga emas yang saya sayangi berada dalam keadaan sihat dan sejahtera.
Hai, Assalamualaikum dan selamat sejahtera. Saya Jururawat Nurul Fatih binti Ahmad. Saya telah berkhidmat di ward geriatric selama hampir 10 tahun. Jadi sebenarnya sambutan Hari Warga Emas Sedunia pada tahun ini, saya berharap warga emas yang berada di Malaysia maupun di seluruh dunia menuju ke arah penuaan yang sihat, sama seperti populasi warga emas yang semakin lama semakin meningkat.
Bagi saya, warga emas adalah untuk dihargai. Pengorbanan dan titik peluh mereka tidak boleh dilupakan. Tanpa mereka, siapalah kita dan mungkin kita tidak akan berada di sini.
Hargailah warga emas kita, ibu bapa, nenek-nenek atau opah, supaya mereka dapat hidup dengan sempurna sepanjang kita bersama-sama mereka. Luangkanlah masa bersama mereka serta sempurnakanlah kegembiraan. Jagalah kebajikan mereka kerana ingat satu hari nanti kita juga akan jadi warga emas seperti mereka.
Hello everybody, I'm Terence, I'm a geriatrician. My hope for this year's International Day for Older Person is that every older person feels valued, feels included, and will always be part of everything that we do. They're a group that needs us to care and to look after. Let's not forget that. So happy International Day of Older Person. Take care.
Selamat Hari Warga Emas Sedunia, dan saya berharap that semua dari kita, terutama sekali generasi muda, dapat menghargai semua kita punya warga emas di Malaysia dan seluruh dunia, kerana tanpa mereka tiadalah kita. Tiada dulu, tiada yang lama.
Hi, happy International Day of Older Person. We hope you love them as much as we do.
Wishing everyone Selamat Hari Warga Emas Sedunia. We should always love, cherish our old people and take a good care of them. Thank you.
Walaupun berusia, namun warga emas perlu dihargai.
Kekuatan fizikal dan mental harus kuat seiring dengan umur. Selamat Hari Warga Emas Sedunia.
Happy International Older Persons Day.
Selamat Hari Warga Emas 2023.
Healthy aging process.
Selamat Hari Warga Emas kepada seluruh warga emas di Malaysia.
Selamat Hari Warga Emas.
Selamat menyambut Hari Warga Emas Sedunia.
Selamat menyambut Hari Warga Emas Sedunia.
Selamat Hari Warga Emas Sedunia.
Happy International Day for Older Person.
Jadi dengan itu saya mengucapkan Selamat Hari Warga Emas Sedunia.
Welcome back to our webinar. Let's dive right into our second session for today. How can we age healthily? What's the secret, or is it a secret? We have Dr. Chong Jin Yen, a primary care physician in University Malaya Medical Center and a senior lecturer as well, to share on lifestyle measures for healthy aging. Dr. Chong, the floor is yours.
Thanks for having me. Okay, hi, I'm a family physician from University of Malaya Medical Center, the primary care department. Full name is Chong Jin Yen, call me Ian. So today, I think I'll share some knowledge, things that are important, things that you already know about, but with a bit of depth, a bit of twist. Hope you find it helpful. Thanks. Oh, yeah, sorry. Okay, so let's start by asking this question. How do you imagine an ideal life? What does it mean to have a good life? So to me, it's to maintain my sharpness, to stay sharp, to be independent, like this gentleman here. Be free to move around, to travel, do what I like to do, not be dependent on others, not to trouble others, to be respected, to show and to be surrounded by love. Well, that's for me, but I believe everyone finds that desirable as well, right? How do we achieve this? Well, believe it or not, people have looked into it. They found that more or less there are consistent themes that brings the meaning of aging well. And it's not only about money. Now, if you haven't noticed, aging begins from birth. So, you know that aging is actually a lifelong process. So while this means you gain more investing in your health earlier, but it doesn't mean that it's too late. It's like investing in your future, gold, stocks, property. Yeah, the earlier you start, the more the returns. But you can also start much later, and it's better than not starting at all. Okay. All right, this brings us to the importance of aging healthily. So healthy aging is not just about avoiding disease, because we know that most older persons have at least one chronic condition, one long-term disease. And in fact, 40% of older adults have more than one chronic condition. So what does it mean to age healthily? I'm sure everyone has heard these terms like this, aging gracefully, or successful aging maybe, maybe positive aging. Yeah, the terms evolve over time. And according to the WHO, the World Health Organization, they define healthy aging as the process of developing and maintaining the functional ability that enables well-being in older age. So notice the term functional ability there. So in the past, there was a well-known concept of successful aging. Maybe some of you have heard of this before. It consists of 3 components that I think a lot of you still hold true. One is being free of illness or disability. And number 2 is maintaining high thinking capacity and physical function. And the third one is to remain engaged with life, which means social and productive activities. But we know that most older people have at least one condition, so being free of illness is no longer possible. But it doesn't stop people from living a satisfying life, right? So what does function mean? Basically, it means being able to meet your basic needs, to be able to learn, grow, and still make decisions for your own self, to be mobile, to be able to move around, to be able to build and maintain relationships, and lastly, most importantly, to be able to contribute to society. So now, that's from us. What about when we ask people about aging healthily? So there are studies asking the perceptions of Malaysian seniors about aging gracefully, and they see that. They mention that, it doesn't appear here, right? First of all, it's financial independence, yes, very typical Malaysian. Quality in health and healthcare support, and meaningful social networks. So in other regions, the factors that are most mentioned are engagement, maintaining independence, and belonging to a community. So now, as you can see, some of the themes are quite consistent. We agree that health is not the only concern, but how the life is lived is. Having a life of meaning, purpose, and connectedness is still achievable in the setting of long-standing illness and functional decline. So from here, I'd like to introduce what experts believe contributes to a good life. So things that are within your control to improve your life. So these are the 6 pillars in lifestyle, a healthy lifestyle, which experts say is the basis of health. They went as far as to say that lifestyle is the root cause of most major chronic diseases, well, which are your 3 serangkai, as well as cancer. So before I continue, please remember to be wary of your existing problems that you may have that may preclude you from doing some of the upcoming things. For example, those on warfarin, the blood thinner, be careful with your leafy greens. Those with kidney disease, be careful with high potassium foods, for example, too much fruits. Those with existing heart disease, be careful with starting exercises too hard and too fast. So with that, let's move on. Our first pillar, we have food. I'm not going to dive much into this because we have an expert in diet to share his part later, but I'm just going to leave this here. Focus on whole food, plant predominant eating patterns. Studies have consistently shown plant-based foods, especially whole grains, veggies, fruits, which are the basis of the famous Mediterranean diets and a lot of diets that are evidence-based, improve health as well as prolong life. Now, whole foods means that they are unprocessed or minimally processed foods. Now, these are rich in nutrients but lower in calories, which means you get more value out of the foods without gaining weight due to the excess energy. And as you already know, how you cook them also matters. Now, lower heat cooking methods, for example, boiling, steaming, preserves nutrients and avoids the production of harmful byproducts in foods. And this is also a well-known pillar we talk about when we talk about healthy lifestyle. So I'm going to introduce a few concepts here. On the left is physical activity. So you have gardening, walking to the store, house chores like cleaning, washing the car, and also exercise. These are physical activity. But we don't call house chores exercise. So exercise is when you dedicate time just to do some physical activity, specifically to improve part of your health or fitness. So that's the middle picture. This gentleman is all geared up to walk on this treadmill, not to go anywhere, but just to improve his fitness. So that is exercise. And on the right is sedentary lifestyle. You may have exercised enough, which people know is doing like 30 minutes of exercise most days for a week, or strictly speaking, 150 minutes of exercise divided to most days of the week. But even if you have exercised enough, if you spend the rest of the day sitting or lying down, then damage can still happen. So by breaking your prolonged sitting habits, you gain additional benefits. So what's the point of me introducing this? If you exercise regularly and don't sit for too long daily, you get double the benefits. That if you got no time to exercise or you do not have the capacity to exercise, then just by reducing your sitting time, you're already getting half of the benefits. Now, the third pillar is risky substances. This includes smoking, alcohol, vaping. Dadah, we don't have to touch because we know those are clearly harmful. But let's talk about alcohol first. So alcohol, people use it to calm the brain, but at a cost. Using it to deal with stress or sleep, it trains your brain to need it. So which puts you at the risk of side effects of alcohol. For example, safety problems, injuries, liver problems, fat accumulation, and pretty extremely can lead to brain damage as well. A lot of people use it to help their sleep. Yes, it does speed up sleep, but it also changes how the sleep cycle is. Basically, your sleep consists of a few stages, and although you get to sleep faster, but you'll have more waking episodes, and the sleeps that has less dreams. So quality of the sleep suffers. Overall, a person wakes up feeling unrested. And for smoking, I think everyone knows smoking is harmful. Some move on to vaping, but it's just as risky because they don't control the amount of contents inside, especially the nicotine. So now, nicotine is the active ingredient that hooks onto your brain, which is why it's so difficult to quit. To handle this, I think it's best to speak to your doctor, your family doctor, as we have effective ways to help. Next up, we have positive social connections. Now, humans thrive on social connections, whether it's family, friends, colleagues, acquaintances. A good social connection is, how do we define it? It is not defined, but how do we characterize it? It's a relationship where one feels seen, one feels heard and appreciated, where they derive sustenance from. So in short, basically, a relationship that gives you positive vibes, that you feel positive out of. Okay. There are studies finding that one of the biggest factors that predict longevity was meaningful relationships. This means those who are socially isolated was linked with shorter lives. Then, the next pillar would be restful sleep. Notice I added the word restful there. What's important is whether the sleep was restful, not so much the number of hours. We think we did not sleep, but our brain definitely goes to sleep every day. Yeah, our sleep depends on the circadian rhythm. So it's like a clock in the brain, and each of the organs have their own internal clock, but it syncs with the main clock. So our bodily functions depends on this clock. So to sleep well, basically we form a routine that follows the clock as much as possible. It takes cues to facilitate sleep. For example, the light exposure, the comfort level, the environment that you sleep in, the temperature. Okay. Although, one important thing is maybe it's good to get checked if you have slept enough hours, yet you still feel unrested. There might be conditions that could be treatable. And lastly, we have managing stress and emotional well-being as well as mental health. Now, actually, this is arguably one of the more important ones because feeling overwhelmed of having mental distress often leads to poor lifestyle choices. Lifestyle would be deprioritized, meaning that they no longer think that they need to do it, or there won't be enough motivation or energy to take care of yourself. So briefly, stress management is about recognizing that stress is not always bad, and reframing how we perceive stress is needed to improve. Stress means that you're dealing with something important to you. So in short, your perception of stress is what determines whether you thrive or crumble under pressure. It builds resilience. So one of the ways touted to manage stress is by mindfulness training. In brief, mindfulness is basically purposefully putting your attention towards something and that one thing only, while trying to observe your thoughts neutrally. Well, many times we have a lot of automaticities where we react to our emotions, of course, based on our whole 60, 65 years of experience in life. But by being mindful, we somehow relearn to pause, to take time to recognize our emotions and then respond to them, rather than to automatically react or judge them. I like to describe this as rediscovering innocence. And of course, if your mental distress affects your function, as in you cannot perform your daily routines as usual, please seek help. Yeah, not all consultations need to end with medications or lifelong medications. And the choice is still yours for treatment. Now, I'd like to share some tips. I'm sure many of you have been doing this, if you have the abilities to, but here goes anyway. Find things that cover several of the 6 pillars. For example, exercise groups in the morning, Tai Chi, line dancing groups. Now, these cover several pillars because it covers physical activity and social connections. And if you really take it to the next level, you share healthy lifestyle tips with each other. Just be careful with people giving bad advice lah. So another good one is playing sports. Now, this is a bit controversial as some consider sports to be high risk for injuries. So do be careful of what you can and cannot do. Sports fosters relationships. It's an expressive activity which reduces stress. And on top of that, it's a physical activity. Examples are those who can afford it, maybe golf, ping pong, badminton, and I've seen many older persons taking part in tennis, bowling, and they still continue to do it throughout their lives. Another one, volunteering for a cause or joining an organization. It gives meaning to life where you feel you're part of something bigger than yourself. Well, I've met many retirees in health organizations. They utilize their past expertise and continue to contribute. Now, there's this major concern about memory problems. So I think we're going to touch that a bit. Mild memory decline is expected as we age, but not until your daily routines are jeopardized. So a few things to keep yourself sharp is basically to learn something new, like picking up a new language or perhaps progress with whatever existing skills or knowledge that you have. This will add stress, definitely, but as I explained, if you're not uncomfortable, you are not learning. Older people can still learn, although just a bit slower. Now, I've talked about expressive activities. Examples are like playing music, making art, writing. These can help stimulate your brain, which may have some short-term benefits towards memory and sharpness. And finally, here are some final messages I'm leaving with you. It's time that we relook at our perceptions of our value and worth. The traditional view that retirement is the point where we are no longer fit to contribute no longer holds true. There is so much that our seniors can offer to the world. And the second point, as mentioned earlier, investing should start early to reap maximum benefits. But even if you've started late, you still gain some of the benefits. So start now. Well-being is also housekeeping. To keep your home tidy and functional, regular housekeeping is needed. Same as your body. You may argue that you can delegate housekeeping to others, but not your body. But I would say you too can delegate your healthy diet to a cook. And finally, we should have appropriate expectations about aging. Not too optimistic till we think we can fall and recover like a 30-year-old, but also not too relaxed until we consider things like being unable to hold your urine as normal. When in doubt, discuss with your doctor. And with that, I thank you.
Thank you very much, Dr. Chong, for such a great sharing for us in practical tips of how we can age healthily. So next up, most of us or our older loved ones are on some form or type of medication. But are we managing or taking the medications correctly? Do we know our medications well? I am pleased to introduce our next speaker, Madam Nicole Kumari, a pharmacist at University Malaya Medical Centre, to share with us more on paying attention to our medications. Madam Nicole, I hand over to you.
Thank you. Good morning, everyone. My name is Nicole Kumari. I'm a pharmacist here in UMMC. And okay, so the title of my talk today is Pay Attention to Your Medication. First off, I just want to wish everyone Happy International Day of Older Person 2024 from our pharmacy department. So this morning, I would just like to talk about the journey of a patient after he or she completes their consultation with their doctor. After doctor's appointment each time, the doctor will prescribe a list of medication for their patients. And when the doctor prescribes, it will be through the computer. And with just one click of the button, the list of medication will be sent to our pharmacy. And there, the medication will be packed and prepared for the patient when they come to our pharmacy. So, as you can see here, the doctor will hand you this slip to collect your medication from our pharmacy. So this is actually your queue number. Your queue number is actually it consists of the patient sticker, which is the full name of the patient, and also the registration number of the patient. And besides that, there is a 4-digit calling number, which indicates at which counter you should be waiting at the designated counters in our pharmacy. And besides that, it will also write the date of the prescription of which your doctor prescribes. You can come and collect our medication in our pharmacy, and as you can see below, there's a list of all the satellite pharmacy and our main pharmacy. Our main pharmacy is Pharmacy Pesakit Luar, which is located at the ground floor of Bangunan Ruka. So when you arrive, if you have that queue number, you no longer have to take a queue number in our QMS machine here. You only take a number when you have a refill of medication, whereby you have to bring your own prescription. And this services is only until 5:30 p.m. on weekdays. Besides that, there's also an option to have a consultation with a pharmacist at Counter Khidmat Pelanggan. If you have any medication queries about your medication or you need further counselling about your medication, feel free to take a number and wait for your turn over there at the counter. And for C is ubat tidak dituntut. These are medications that have been unclaimed. After the doctor's appointment, let's say you're too tired to come to the pharmacy to collect your medication, no worries, we will actually keep your medication in our pharmacy for 5 working days. So you can collect it within 5 working days before we return the medication back to our bins. So an important thing to ask is, to everyone who comes to the pharmacy, do you make it a habit to always check your medications once you receive it? It is important to ensure that you receive the correct drug, medication, the dose and route, quantity, and also for the right patient. It is important because any errors can be detected and rectified on the spot in our pharmacy before you even leave the pharmacy. But therefore, it's always important to check your medication when you receive it from our counters. So just to point out, this is our prescription here in UMMC. As you can see, our prescription here is actually complete, very complete, with all the patient's detail and also the list of medications. And below, you can see the column here. Once the medication has been supplied by our pharmacy staff, we will actually indicate the amount supplied, whether it's 1 month or 2 months, and the date of the next collection will be written here as well. Besides that, our pharmacy staff will also stamp their initials on each prescription, whereby to indicate that each prescription medications have been packed, checked, verified, and supplied before the patient receives it. And a new feature that we have recently added in our prescription, which is the QR code. As you can see on the top right, a QR code has been made available on each prescriptions. And this is for each patient. After they receive their medication, they can actually scan this QR code. It will directly link you to our pharmacy portal homepage. And there you can see all our value-added services that we have in our pharmacy. And this is to encourage all the patients to just to check out which value-added services that is favorable for them. So I will touch on the value-added services later on. And next on, I would like to point out on how do you check your medication. We always encourage patients to check their medications when we dispense to them. And what are the ways that you can check your medications once it has been dispensed? As you can see here, you will receive your prescription and also your medication, which a medication label will be pasted on your medication. All you have to do is just to check the name of your medication on your prescription and cross-check it with the medication you have received, whether it's the correct strength, the correct dosage form, whether it's a tablet, a syrup, or a capsule, the directions on how to take, whether the doctor has upped your dose from 1 tablet to 2 tablets, to the frequency of it, whether it's once a day, and also the directions of how to take, whether there is a special instruction, it will be also stated on the medication label. For example, to take with or after food. And besides that, make sure the quantity supplied is correct, whether it's 2 months or 1 month, and also the patient's name and registration number. You can cross-check it on the prescription and also on the medication label. So just want to remind everyone to remember to check all your medications before leaving the pharmacy. So, and as short, we just want to ensure that you receive the correct medication, dose, route, quantity, and for the right patient. And another thing that I want to point out is always keep us informed. Bring all your medication to every hospital visit. I think every doctor would appreciate that. And this includes your prescription medications, over-the-counter medicine, herbal medicine or tonics, vitamins, and also supplement. The doctor can review all the medication that you have during your consultation. Having this knowledge is very important for the doctors and also us, the pharmacists, to ensure that you receive the appropriate medications, identify any problems with your current medication, and ensure that you go home with the correct medications. So as I mentioned just now, we have a few value-added services. This will ensure, I hope, to ease your medication collection process if you are tired of waiting for your medication in our pharmacy. So I would like to introduce Pick and Post Pharmacy here in UMMC, formerly known as PharmCare. So Pick and Post Pharmacy is currently located at the ground floor of our Bangunan Plaza PPUM. So just a guide, it's actually right opposite of 7-Eleven. At Pick and Post Pharmacy, we actually offer 3 types of services. The first one is counter collection. Counter collection is whereby medications will be prepared in advance for collection at the Pick and Post Pharmacy. So you will have a date of collection for counter collection. The second one would be Med Station. So Med Station is whereby patients or caregivers can collect medications from an automated secure locker at any time. I will explain this later on. It's just a locker for your medication. And the third one will be medication by post. So if you have repeat medication, we can deliver your medication right to your doorstep. So the first one is counter collection. Medications will be prepared in advance for collection at the Pick and Post Pharmacy. This is important for everyone to know that you can skip the queue for your medication collection. So all you have to do is, after your first collection of medication at our pharmacy, be it the outpatient pharmacy or any satellite pharmacy, you can bring your prescription along. If you have a balance of medication to be refilled, you can come to the Pick and Post Pharmacy counter to do a booking for counter collection. So as you hand us the prescription, we will actually book your collection in our system, and a booking number or date will be given to you. And on the collection day, an SMS reminder will be sent right to your phone. And all you have to do is to bring your prescription to Pick and Post Pharmacy, and the medication is prepared in advance and ready for your collection, so you can skip the queue. So an important remark is that there are no early collections, so you have to follow the booking date that we have booked for you, and the medication will be kept for 5 working days from that collection date. So let's say if you can't come on that collection date, no worries, we will keep it for 5 working days. But if you can't come during that 5 working days, just give us a call. We will actually reserve your medication for when you can come next time. So the next one is Med Station. Med Station is fairly new, that has been introduced recently. Our locker here, as you can see, is placed at our plaza ground floor and is right beside the entrance door. And this locker is made available for medication collection at any flexible hours. As you can see on the bottom right, you can see from Monday to Friday, you can collect your medication anytime from 7 p.m. to 9 p.m. And for weekends and public holidays, you can collect it from 8 a.m. to 5 p.m. And the service charge, we only charge 3 ringgit per reservation. So the steps on signing up for the medication in locker, you have to submit a request through a Google form submission, and an email confirmation will be sent to you, and you will receive a response actually within 24 hours during our operational hours. So any payment is to proceed via payment online through the Patient Journey app or the UMMC single sign-on platform. After that, you will receive an email confirmation with a PIN code or QR code that is to be used during collection. So once the medication has been kept in the locker, all you have to do is to come at any time to collect the medication within 72 hours. So after 72 hours, we will remove the medication, and it's a sign that you won't be collecting it from our locker. So next, last is our medication by post. If you have any repeat medication delivery, we are able to deliver it right to your doorstep. And how to request for medication delivery? It is through UMMC Patient Journey app. You have to download the app and log your information inside. And as you can see, the main page here, you have postage of medication. The image here, you can just click on it and to read our terms and conditions and proceed with the request. All you have to do is to choose the clinic according to the medication you want to be delivered. You want us to deliver to you. After that, just fill in your delivery address, phone number, and you can remark anything that you want to tell us in the remark column and then submit. So once you have submitted your request, it will be processed within 1 to 2 working days. So through the app, you can actually check the status of your request in the request tab or the approve tab. So once the delivery has been confirmed, you will receive a confirmation email by Pick and Post Pharmacy. So this email actually contains your medication list, posting date information, and if you need to submit a GL or make your payment online. So for paying patient, all you have to do is to use the Patient Journey app again to make your payment in the Approve tab and pay within 3 days, which is 72 hours. So the booking will be cancelled automatically if you fail to make the payment within 72 hours. So medication by post, these are the delivery charges. So for medication by post, we deliver cold chain items and non-cold chain items. For cold chain items, these are items such as insulins, injections which need to be kept within 2 to 8 degrees Celsius, and also some eye drops that has to be kept cold chain as well. So we will deliver the medications at 15 ringgit within the Klang Valley. So with your postcode, we will check your postcode thoroughly whether it is within our delivery area, and we will proceed with that. So on the morning of the delivery day, the pharmacist will actually pack the cold chain medication in a special thermal insulated pouch together with an ice pack, and the medication will be put inside. And the rest of the medication, the non-cold chain items, will be packed together, and our delivery partner will actually pick up these parcels and will be sent within few hours to the respected addresses. So for non-cold chain items, it's a bit cheaper. For West Malaysia is 6 ringgit. For East Malaysia is 12 ringgit 50 cents. We are able to send inhalers, cream, ointments, tablets, anything that is non-cold chain medication. And for payment for the delivery charges, you can pay with two payment modes, which is the online payment. You will receive an SMS from eSIMS, which is our delivery partner, within 3 to 7 days before the scheduled delivery date. So all you have to do is click on the link to make the payment online. Let's say you have forgotten and you didn't make the payment online, no worries, there is a cash on delivery for the parcel. Therefore, it is always important to be present at your delivery address upon the delivery date. So this is the Pick and Post Pharmacy. Anything you can reach us through email, which is farmcare@ummc.edu.my, or call us at this number in our working hours, during our working hours. So that's all from me. Thank you so much for your attention. And always remember to just drop by the pharmacy to get your medications refilled or sign up for our value-added services that we have come up with. And just want to remind everyone that medication safety is our top priority. So with that, I hope that everyone will be patient when we prepare your medications here at our pharmacy. So thank you so much.
Thank you very much, Madam Nicole, for sharing with us on the journey of a patient coming through to our pharmacy in UMMC and how the process takes place. And we hope that your journey with us would be much easier and smoother. So thank you, Madam Nicole.
Thank you.
Our next topic is about feeding the mind. And we will be this topic will be presented by Mr. Mok Chuzen, our dietitian at University Malaya Medical Center. He will be sharing simple nutritional strategies for dementia care. Mr. Mok, I will hand it over to you.
Thank you so much. Hi, good morning everyone. My name is Mok Chuzen. I'm a clinical dietitian from University Malaya Medical Center. So in the honor of International Day of Older Persons this year, I will be sharing some nutritional strategy for those people who have dementia. So, dementia is actually an umbrella term for the loss of memory and other thinking abilities that can be severe enough to interfere with the daily life. So, if you just have some forgetful events, so don't worry too much about the dementia. Okay, among all the cognitive impairment, Alzheimer's disease is one of the most common one in the dementia umbrella. Okay, so when we talk about nutritional issue, we know that the cognitive and physical changes in the patients with dementia and Alzheimer's disease, they can actually cause some issue in nutritional challenges. For example, it can cause unintentional weight loss, decrease in the appetite, or even overeating. Swallowing difficulties is also very common, dehydration, and some behavioral symptoms and feeding challenges. Okay, so let's look into it one by one. So weight loss is a serious concern for patients with dementia. It can be caused by reduce in the appetite, difficult in eating, increase in the energy expenditure. Some people with the dementia, they can be wandering around, and also they couldn't rest well at night. So they actually increase in the energy expenditure. Some changes in the metabolism will also cause them to gain weight. So it is highly recommended for anyone with dementia or Alzheimer's disease to actually monitor their body weight. Okay, so the family member can help them by monitoring their body weight regularly and document it in a booklet or even a piece of paper, so that if there is anything happen, we know that what is the body weight changes for that particular patient. And we have to understand, even though some people with dementia, they might have diabetes or even they have chronic diseases such as high cholesterol, dietary restriction might actually limit the food and fluid intake. So we might actually look into diet liberalization, meaning that they can eat whatever food that they want in a smaller portion without too much of dietary restriction. Okay, so if someone is having unintentional weight loss, we should offer them a balanced diet that includes a variety types of food from all the food group. Okay, it can be coming from carbohydrate, protein food, animal protein, plant-based protein. So it is very important to have fruits and vegetables as well. So do not omit any single food group. Okay, you can also incorporate high-calorie food to increase the calorie intake for those who have poor appetite, such as avocado, nuts butter, full cream milk, or even some oil. Okay, for example, some people will think that the cholesterol is high, so they dare not to take full cream milk. To be honest, full cream milk doesn't really increase your cholesterol level in your blood, but it will give a bit of extra calorie for those who have low body weight. Like for example, some older persons, they might not be eating solid food well, so they rely on porridge. You might add on some sesame oil or even olive oil into their porridge to increase the calorie intake as well. If their intake is still very low after some effort has been taken, you can actually offer oral nutrition supplement. I will talk about it later to the patients with dementia so that they can meet their energy needs. If you really couldn't do anything or you don't know what to do, you can consult a dietitian so that we can have a personalized nutritional plan for individual. Okay, so oral nutrition supplement is something like a milk, but it is not actually a milk. It is an easy and convenient way to boost the calorie and protein intake of someone. It comes in different form. It can be in liquid, it can be in powder form. It is high in calorie and protein. At the same time, it has different flavor. So it is not something like you only drink the milk every day. You can have vanilla flavor, chocolate, cappuccino, tropical fruit. There's so many flavors to cater the needs of different patients and also their preferences. Okay, so how do we know if someone is having a good body weight? So I think many of you know how to calculate the body mass index. This is the easiest way that we can actually determine whether someone is in a healthy body weight or not. Of course, we can actually measure the lean muscle mass, we can measure the body fat, but not everyone have the body composition analyzer at home. So even a simple scale, you can help your loved one at home to calculate the BMI. So the easy way is to divide the body weight in kilogram with your height in meter for 2 times. Okay, so most of the time when we talk about BMI cutoff point, we know that for general population, it is in between 18.5 to 24.9. But for older persons, especially for dementia, it is a little bit different because we wanted to look into the BMI in between 23 to 30. Research shows that for the BMI lesser than 23 in older adults, they have higher chances of osteoporosis, risk of falling, and even hip fracture. So this is also very common in older adults. So we want to avoid that. So we raise the bar. The normal weight should be more than the BMI of 23. But as for the BMI more than 30, it increases the risk of chronic diseases as well. So we wanted to see if someone at the older age, they can have the BMI in between 23 to 30. I'm not going to talk about how to reduce the body weight or increase the body weight too much in this presentation, but it is all looking into the energy balance. So you do not have to practice a specific type of diet just to lose weight or increase the body weight. Okay, but what if an older adult with dementia, they claim to have decreased appetite or even anorexia, they don't want to eat? We have to understand what is actually the reason behind it so that we can solve the reason to improve the appetite. So the possible reason can be ranging from not recognizing the food. At the later stage of dementia, a patient might not be recognizing the food. When the food coming to them, they look at the food, they do not know how to initiate the eating. Okay, or it can be simple reasons such as poor fitting dentures. So when they are losing weight, their what they call the gum will actually shrink. So when the gum is shrinking, the denture no longer fitting well. They feel painful or discomfort while wearing the dentures. So they might as well not wearing the dentures. So when they are not wearing the dentures, they couldn't chew. They will just spit it out the food. Okay, some simple reasons such as the exercise. It also can cause the low appetite. If imagine an older adult, they are bedbound or they are bound to the chair, they are sitting all the time throughout the day, they are not exercising at all. So when they are not moving at all, they don't feel like they want to eat. Okay, so these are common issues that can cause decrease in the appetite. So if they have decrease in the appetite, we don't want to force them to eat, because when we force them, they will feel like it will be even worse for them. Okay, they can get the stress, they don't even want to eat anymore. So we try to create a relaxed and pleasant mealtime environment for them by setting up the table, using a visually appealing dishes. Okay, we don't want them to be distracted by the iPad, by the television. So we play some soft music for them to create a calming atmosphere, so they know that when you play the music, it is the time for their meal. So it will also help them to prompt that's the mealtime. Okay, we can offer them their favorite food, okay, or foods with strong aroma. So it is very often that we serve the food for older persons in a cold temperature. because we might just cook at one time in a day, then we keep it until the next meal, then we just serve it like that. A cold food actually reduces the taste and the aroma of the food. So they already have a decreased sensation of taste and smell. If the food is no longer tastes good to them, they're not going to eat. Okay, but we can actually help them by enhancing the flavor with some herbs and spices to give them more flavor rather than giving them more salt and sugar. Okay, so at the same time, we can actually provide them a smaller portion of food rather than a big plate of food that can be too overwhelming for them. And especially for the patients with dementia, at the later stage, they couldn't actually finish the food at a shorter period of time. So if you give them a lot of food, it takes longer for them to finish. It is quite tiring for them as well. Okay, so on the contrary, some patients, they are not eating lesser, they are actually eating too much. We understand that the changes in the brain will actually cause the dysfunction that regulate the appetite and satiety. So they might have a specific craving towards foods. Like for example, they might want to eat curry puff all the time, or they want to eat rice all the time. They usually have a specific food that they crave for. Okay, so how can we help them? We can set a regular meal and snack time with them. Okay, then there is one tips actually given by my patient. They share with me that they have a whiteboard, okay, with a schedule of time for meal with the patient. So when patient eat a meal, they will just have a signature on the whiteboard or have a magnet on it, so they know that they have taken their meal. So when they ask for it again, you just show them that, oh, you have eaten. I guess this is also an easier way to help them oriented to the real world. Okay, so we can offer the low calorie and then nutrient dense snack if they keep on asking for food. Okay, we can give them some fruit, vegetables, yogurt, okay, some snack which is lower in calories such as nuts and seeds. It is also good for them as well. Okay, but do not keep too much of high calorie snack at home, like the cheese, potato chips or keropok. All these things, if it is accessible to the older adult with dementia, they might be taking it without any control. Okay, so another common issue for patients with dementia is swallowing difficulty, or we call it dementia, dysphagia. Okay, at early stage, you might notice that a patient in dementia, they may take longer to finish their meal. Probably usually they take 15 minutes to finish their meal. And when they started to have dementia, it might take more than 20 to 30 minutes because they tend to forget they are eating and they will keep the food in the mouth, so they are not chewing and swallow. Okay, but when it progresses, it can cause coughing and choking because the food can go to the airway and cause infection. Okay, so if it is happening, we can actually change the consistency and the texture of the food and fluid to help reducing the aspiration and malnutrition risk. Okay, so if you have this issue, the first thing is not seeing a dietitian. You should consult a speech and language therapist. They will do a swallowing assessment to determine the appropriate food texture and liquid consistency. Then a dietitian will teach you how to modify the texture by preparing minced diet, pureed food, or even soft texture food to improve the swallowing. Okay, so these are some examples of different levels of dysphagia diet. Okay, we have dysphagia pureed diet, minced and moist, and soft and bite-sized. So the food are almost the same like what we have been preparing for the family. It's just that we make sure the texture is easier for the older adult with dysphagia to swallow. Okay, but even though someone doesn't have dysphagia, if they have loose teeth or they do not have good dentures, you can actually prepare food with softer texture. So protein food is something that they always omit. Whenever that I meet a patient, they say, oh, I don't have a denture, I don't have teeth, so I just chew the meat with my gum and spit it out. Okay, so you can help them by choosing a tender cut of the meat or poultry, by looking into the tenderloin or even the drumstick. Fish is also one of the very soft texture protein food as well. So you can help them by cutting the meat into the cube or even mince the meat. Okay, it'll be a lot easier for them to scoop, feed themselves, and chew, swallow. Okay, but when we cut the meat and cook it, the meat can become very tough. So you can actually marinate the meat by adding in some egg white, cornstarch, soy sauce, and then this will actually form a coat to prevent the moisture from escaping the meat when we cook it. Okay, so there are also other very soft texture protein food such as egg, tofu, and dal. You can add it into the daily meal. Egg is a versatile protein source that you can add it literally in every recipe. For example, you can have hard-boiled egg in the morning, scrambled egg with your toast, a steamed egg with minced meat or prawn in it. So you can increase a lot of protein intake for a patient if you have difficulty in chewing. Okay, but it is not only protein, vegetable is also another issue. So normally we will recommend an older person who have difficulty in chewing to get the green leafy vegetable without the stem, or get the starchy vegetable. You can steam the starchy vegetables such as pumpkin, potato, sweet potato, and then it can be very soft for the older adult to eat. Okay, in Malaysia, you will never run out of idea how to get a softer texture of fruit. So I actually attach the list of it, so you can just screenshot and then you can prepare it for your loved one. Okay, so when we talk about fiber, we cannot leave the liquid as well, or fluid, because when we eat a lot of fiber without adequate fluid intake, it can cause constipation. But older adult that tends to drink lesser fluid, it can be either they don't want to drink because they might have limited mobility, they are on the bed most of the time, they don't want to go to the toilet very frequently, or they don't want to waste the diaper, so they reduce the fluid intake. Or simply because they don't feel the thirst to drink, so they don't have the urge to drink, they forget to drink. Okay? So it is very important to have about 25 to 30 ml of the liquid for every 1 kilogram of body weight for an older adult. Okay, so for example, if your father and your mother is about 60 kg, the daily requirement would be about 1,500 to 1,800 milliliter a day. And the fluid here that I mentioned, it is not only the water, it includes milk, soup, gravy, broth, or even fruit juice that you can actually give throughout the day. Okay, but if they have difficulty in eating food because of dry mouth, and this is very common in older adult, you can, soften the food by dunking the bread, toast into milk or even hot chocolate to soften them. Remind them to take a sip of liquid in between the bites of food. Okay, add some gravy, broth, or sauces to make the food softer and wetter. Okay, you can also offer them sour candy to stimulate the saliva production. Okay, some additional tips you can help them is to use a plain and also non-pattern plate so that they have a good visual on the food. You can also use a plastic tablecloth. For example, older adult, when they have like Parkinson disease, they cannot feed themselves well. They tend to have very messy table after eating. So to make the job easier, you just use a plastic tablecloth. You just throw away after eating. Okay, so help them to check the food temperature. There are sometimes they couldn't identify the food whether it is hot or cold. It can actually hurt them and cause injury or burn. So you just taste the food, make sure it is warm but not too hot for them, so that it can be safer for them. Okay, offer 1 or 2 food items at a time. Okay, to avoid overwhelming the patient. Okay, you can help them just to give 1 dishes first and then followed by another dishes after they finish it. Okay, so allow them to have plenty of time to eat because it might take longer for them to finish. Okay, the last one that I wanted to share with you is how to handle repeated requests for a meal. If they keep asking for food, what you can do is, if you take care of them for long period of time, you will know roughly how much of food they need to eat. You can split the meal into 2 to 3 parts. Give one part of it, like for example 9 o'clock in the morning, you give half of the portion for the breakfast. After 1 or 2 hours, when they ask for food again, then you give the remaining food. So it will help the patient to ease their mind that they are eating, but at the same time, they wouldn't be eating too much that can increase the calorie and cause obesity. Okay, so all in all, we are looking into healthy eating. There is no miracle that we can help the patient with the dementia. So you can use a healthy plate method to have a balanced meal and also a complete meal for the older adult. So we choose at least half of your grain from the whole grain to increase the fiber intake, to eat at least 3 servings of vegetable and 2 servings of fruit every day. And definitely protein is very important every meal. So I think that's all for me. Thank you.
Managing and caring for persons living with dementia can be challenging, and maintaining their nutrition is often very difficult for our caregivers. So thank you, Mr. Mok, for the practical tips and points to help ensure maintain nutrition among the persons living with dementia. In following with our nutritional talk, next we have the issue that Mr. Mok briefly mentioned earlier, which is difficulty in swallowing, also known as dysphagia, and is another common problem faced by our older adults for various reasons. So it is my pleasure to invite Ms. Y Yun Sin, our speech and language therapist at UMMC, to share how to modify food or fluid according to the International Dysphagia Diet Standardization Initiative for older adults with dysphagia. Ms. Y, I hand over to you.
Thank you. Hi, good morning, everyone. I'm Y. I'm a speech language therapist. Today, I'll be sharing with you regarding food and fluid modification according to the International Dysphagia Diet Standardization Initiative. In short, we call it IDC. So we will be talking about what is IDC and the indication for food and fluid modification, the levels of IDC, and the suitable foods in each level. IDC is founded in 2013 by a group of professionals. They are all volunteers from all over the world, which are speech language therapists, dietitians, nurses, OTs, physios, doctors, mechanical engineers, food technologists, and scientists. The aim is to develop an international standardized terminology and descriptors for dysphagia diets that would meet the needs for individuals with dysphagia. So the current reference is the Complete IDC Framework Detailed Definitions 2019. It provides detailed descriptors for all levels of the IDC framework. For more information, you can refer to this idc.org, where you can find the IDC framework over here. So what's for lunch? I believe it's almost lunchtime now, so everyone might be very hungry. So we can choose all kinds of food. If you do not have any swallowing problem, you can choose nasi lemak, roti canai, pastries, char kway teow, or any kueh that you like. But what about, imagine that if you have a toothache, or your tooth just removed, or you have ulcers developed in your mouth, will you still be able to enjoy your food? So what about those with swallowing problems because of stroke, head and neck cancer, brain injury, Parkinson's disease, dementia, and motor neuron disease? They might not be able to enjoy their food. So when and why do we do food and fluid modification? So if you see someone with coughing during mealtime, after they swallow a few spoons of water, after they take a few spoons of porridge, they start to cough. Or you see them doing some throat clearing. They complain of food stuck at the throat, drooling of saliva, and then when they eat, there's some anterior leakage from the mouth, and recurrent aspiration pneumonia or lung infection causing by food and water entering the lungs, unexplained weight loss, prolonged mealtime, and food refusal, doesn't want to eat the food and drinks that they usually want, and many, many more. So these are the signs and symptoms of dysphagia. And if you experience any of this, or if you see someone, your friend or family members experience this, can always refer to the speech therapist. So this is the IDC framework. It has 8 levels ranging from 0 to 7. So the pyramid at the right side, it's the pyramid for drinks level, ranging from 0 to 4. And for food level, it is ranging from 3 to 7. So these pyramids, they provide a common terminology for describing the food, texture, and the drink thickness to improve safety for individuals with swallowing difficulties. So for this level 0, thin fluid, and level 7, regular diet, there is no modification needed for this. Whereas for level 1 to level 4, they will be thickened up by the thickening agent, and the carer training needs to be done beforehand. So these are the examples of the thickening agent available in the market. There are a few more. So let's move on to this level 1 slightly thick fluid. So it is slightly thicker than water, and it needs a little bit more effort to drink compared to plain water. It flows through a straw, syringe, teat or nipple, and it is similar to the thickness of most commercially available anti-regurgitation infant formulas. So the thickness is like this. Moving on to level 2, mildly thick fluid. Again, this one, more thicker needed, and mild effort is required to drink through this thickness through a straw. Moving up, we have this moderately thick fluid, where in food category, it's called liquidized diet. So moderate effort is needed to suck through the straw, and it drips slowly in dollops through prongs, can be swallowed directly, and the texture is smooth with no lumps and fiber. So last time it is called honey thick fluid. Imagine the flow is like honey. So now I'm showing you the flow test. Comparison of level 1 to 3 water level. Oops. Can this video be played? No, can. Can't be played. Okay, we can't play the video, it's okay. So the next slide, this one is extremely thick fluid. It is puree diet in food. So it gets more thick, and it cannot be drunk from a cup, and it does not flow easily. Show very slow movement, but it cannot be poured. So when you tilt the spoon, it can fall off the spoon, and it can continue to hold the shape on a plate. And it's not sticky, and no lumps in it. So the examples of food are pumpkin puree, mashed potato, oats puree. So these are the examples of the spoon tilt test. So if you tilt the spoon, it can fall off easily from the spoon and not supposed to be sticky. Try to avoid food with visible lumps in puree and visible lumps in the yogurt. Okay, moving up to mince and moist diet. This is level 5. So this is cincang dan lembab. How do we measure it? So if you use the fork to press through the food, it can go through the fork prongs. So for pediatric, it is less than 2 mm. For adult, it's less than 4 mm. And the lumps should be easily squashed with tongue. And at this level, minimal chewing is required. So these are the examples of food: minced cabbage, minced chicken, and porridge, not the watery type. Try to avoid watery bubur nasi. And then if you have a patient eating porridge, try to avoid those big size toppings like shredded chicken, bigger size shredded chicken. Okay, and try to avoid bubur kacang at this level. And not fibrous fruit yet, because the fiber is difficult to chew, and probably not juicy fruit like watermelon at this point. Moving on, we have level 6 soft and bite-sized diet. So this type of food is come in dice, okay, as shown in the diagram, where if you use a fork to measure, it is around 1.5 to 1.5 cm for adult. And at this point, chewing is definitely needed, and more tongue force and control is required to move the food and keep it within the mouth. Examples of food are diced tofu, diced chicken, diced papaya. And at this point, try to avoid crunchy food such as popcorn and mixed textures, example cereal with milk. Moving on, we have level 7, easy to chew. So it is actually normal everyday food, but then the food will be softer, okay? And then you should exclude those very hard and crunchy and tough food. And when the patient chew, they should be able to chew without feeling tired easily. These are the examples of food, which are example, steamed fish, stuffed enough to break into smaller pieces with fork, steamed vegetables, or soft rice. Try to avoid food like very hard food, such as the meat texture like beef, or even fibrous food like pineapple. Okay. Which one? This one. Can I play the video? Yeah. Ada. Thank you. Next slide. So this is another video. They use roti canai to make into IDSI level 5 and 6.
Rahsia kelembutan buatku. Dettol Gentle Care.
Yeah, almost ending already. This is the last video. So this is level 5, roti canai. And they put kuah in it. Okay, that's my last slide. Yeah. Thank you very much.
Thank you, Ms. Y. Thank you for sharing with us on how we can manage patients with dysphagia, the different consistencies of food and fluid, the do's and don'ts, and how we can cater better for persons suffering from dysphagia or difficulty of swallowing. So thank you, Ms. Y.
Thank you.
We would like to take a short break before our third and final session. We'll take a 10-minute break to again have a bit of rest, and we'll see you back in 10 minutes.
Assalamualaikum, saya pelajar nursing tahun 3 di Universiti Malaya. Seperti mana anda tahu, umur warga emas mulai pada umur 65 tahun ke atas. Jadi sebagai seorang pelajar dan sebagai seorang anak, saya harap anda lebih mengutamakan penjagaan warga emas daripada kalangan sama ada daripada ibu bapa ataupun keluarga ataupun rakan.
As for my experience posting in the geriatric ward, it really opened up my mind and my soul to take care of these special people with their special needs. So I hope that all of the older people out there to live their life more meaningfully and hope that they will live their life with no regrets. Love you all.
Hi all, my name is Leiting. I'm the patient family, the doctor. My dad was admitted in the PPUM for almost 1 month. Here, I would like to thank all the doctor and the nurse to take care of him. So now he's recovered and he can be discharged in 1 or 2 days time. So I know it's hard to take care of all the old people, also including myself. So I hope all have a happy elderly days.
Hai, saya Tigor. Saya bekerja di Ward 13U kurang lebih 5 tahun. Di sini saya melihat dan memperhatikan bagaimana cara merawat warga emas begitu suka daripada cara merawat pesakit biasa.
Assalamualaikum, saya PPK Hidayah dari Buat Jerry. Saya sentiasa dikelilingi oleh warga emas. Oleh itu saya berharap kesemua warga emas yang saya sayangi berada dalam keadaan sihat dan sejahtera.
Hai, Assalamualaikum dan selamat sejahtera. Saya Jururawat Nurul Fatih binti Ahmad. Saya telah berkhidmat di ward geriatric selama hampir 10 tahun. Jadi sebenarnya sambutan Hari Warga Emas Sedunia pada tahun ini, saya berharap warga emas yang berada di Malaysia maupun di seluruh dunia menuju ke arah penuaan yang sihat, sama seperti populasi warga emas yang semakin lama semakin meningkat.
Bagi saya, warga emas adalah untuk dihargai. Pengorbanan dan titik perlu mereka tidak boleh dilupakan. Tanpa mereka, siapalah kita dan mungkin kita tidak akan berada di sini.
Hargailah warga emas kita, ibu bapa, nenek-nenek atau opah, supaya mereka dapat hidup dengan sempurna sepanjang kita bersama-sama mereka. Luangkanlah masa bersama mereka serta sempurnakanlah kegembiraan. Jagalah kebajikan mereka kerana ingat satu hari nanti kita juga akan jadi warga emas seperti mereka.
Hello everybody, I'm Terence, I'm a geriatrician. My hope for this year's International Day for Older Person is that every older person feels valued, feels included, and will always be part of everything that we do. They're a group that needs us to care and to look after. Let's not forget that. So happy International Day of Older Person. Take care.
Selamat Hari Warga Emas Sedunia, dan saya berharap that semua dari kita, terutama sekali generasi muda, dapat menghargai semua kita punya warga emas di Malaysia dan seluruh dunia, kerana tanpa mereka tiadalah kita. Tiada dulu, tiada yang lalu.
Hi, happy International Day of Older Person. We hope you love them as much as we do.
Wishing everyone Selamat Hari Warga Emas Sedunia. We should always love, cherish our old people and take a good care of them. Thank you.
Walaupun berusia, namun warga emas perlu dihargai.
Kekuatan fizikal dan mental harus kuat seiring dengan umur. Selamat Hari Warga Emas Sedunia.
Happy International Older Persons Day.
Selamat Hari Warga Emas 2023.
Healthy aging process.
Selamat Hari Warga Emas kepada seluruh warga emas di Malaysia.
Selamat Hari Warga Emas.
Selamat menyambut Hari Warga Emas Sedunia.
Selamat menyambut Hari Warga Emas Sedunia.
Selamat Hari Warga Emas Sedunia.
Happy International Day for Older Person.
Jadi dengan itu saya mengucapkan Selamat Hari Warga Emas Sedunia.
Thank you for staying with us for our webinar today. We've reached our third and final session of the webinar. We shall jump right in with Madam Nur Amira Yusof, our occupational therapist at University Malaya Medical Center, who will share with us on enhanced cognitive strategies for older adults with cognitive impairment. Over to you.
Okay, hi, good afternoon. So my name is Amira. So now I would like to share with you all regarding enhancing cognitive strategies for aging adults with cognitive impairment. Okay, first of all, the introduction. What is the cognition? It's a complex system of thought that is made of how you think and process. Okay, so this means that how the cognitive processing, these 6 cognitive areas: attention, learning, memory, language, problem solving, and also decision making. Okay, and what is the impact on age on the cognition? Okay, actually based on Samender et al. 2023, people cognitive function may deteriorate as we get older. So this is normal part of aging, and we cannot control that. Okay, and it is clear that brain change as the chronological age increase. However, the rate of change, the biological age of the brain, and the process involved is less clear. And also from Guley et al. 2016, it says that the cognitive function decline often associated with the aging. This means that as we get older, it's increase our cognitive, our cognitive function is reduced. Okay, so this is the prevalence of the cognitive impairment. Okay, based on National Institute of Aging (NIA), 87% of individuals has good cognitive function into old age. This means that another 23% may develop the cognitive impairment, including dementia. Okay, based on Alzheimer dementia also, 1 out of 9 aging adult above 65 has Alzheimer disease, and 1 out of the 3 age of 85 has Alzheimer disease. This means that when we get old, okay, so it's increase the possibility of getting the cognitive impairment. And this cognitive impairment may lead to decrease in life quality of elder and increase of dementia and mortality. Okay, based on WHO, the pace of population aging is much faster than in the past. So estimate between 2015 and 2050, the proportion of the world population over 60 years will nearly double, which is from 12% to 22%. That means we're getting more elderly person in the future. Okay, so now the strategies to keep brain healthy. There is many studies has demonstrated that the brain may continue to grow as long as you learn new information and frequently exposed to intellectual stimulation. Okay, how does this cognitive training has any effect on that? Okay, actually there is only a few scientific data to support this cognitive training can increase the cognitive ability. However, now we get into a growing body research indicate that this cognitive function is working. Okay, what is cognitive training? Okay, from the occupational therapy side, we have 3 cognitive intervention. The first one is cognitive rehabilitation, cognitive stimulation, and also the cognitive training. So, but today I want to talk about cognitive training, which all of us can do at home. Okay, it's a non-pharmacological form of treatment that targets specific cognitive function. For example, you want to target the memory, the attention span, or problem solving, and many more. Alright, it can be conducted using computer, delivered in person, either individually or in a group. Okay, who can do this cognitive training? Like I said before, it can be it can be healthy elderly. Even healthy elderly can do this. My cognitive impairment patient and a person with a mild to moderate Alzheimer disease. Okay, even though these studies are still thin, but at least this is one way to maintain our cognitive ability in order to lower down the risk for developing Alzheimer or any other related cognitive impairment. Okay, how does it work? How this cognitive training works? Okay. So, if you can see the image, the presynaptic neuron release a chemical that we call transmitter, which facilitate communication between the neuron and enabling various brain and body function. Okay, and the connecting of this synapse are essential for enhancement of cognitive function, including the memory formation and learning. So indirectly, it can improve cognitive ability to brain activity. Okay, so this is few example of cognitive training which everyone can do at home, okay, anywhere. Alright, okay, when we talk about the cognitive training, it can be the mental exercise, and then some use the words like brain activity. It's just the same, okay. And then is there no specific type or protocol on how to do this cognitive training, but as long as you occupy your brain into something, we can consider that one as that is cognitive training. Okay, the first one, memory game. Okay, usually the patient with dementia have this problem, the memory. So we can train the brain to code and retrieve. Okay, for example, you can recalling a place or a short list. A short list of maybe animals. Okay, usually sometimes we ask the patient to list down. For example, you can list down 5 cities in Malaysia. You can name a place that the most favorite place that you want to visit. Okay, so indirectly patient will think on the place. Alright, it may look simple or easy for the one who has normal cognitive function or high cognitive level, but for some who has the cognitive impairment or dementia, it may be difficult for them. Alright, okay, for next one, music. You can listen to the music, singing along to the music, moving to the beats of music and playing an instrument. Okay, this kind of activity will stimulate various parts of brain and promote neuroplasticity. Okay, the next one, computerized cognitive training by using computer, video games or apps. Okay, actually nowadays there is lots of games inside the computer apps, even your phone. You can play a memory game inside your computer. You just Google it and you can play on the computer. Okay. And then the next one, spatial reasoning. Okay, this kind of activity needs the ability to imagine relationship and use this information to reason and problem solve. Okay, if you see the picture below, okay, you need to find what figure can be made from this shape without resizing it. So this one, okay, where to get this kind of activity? Actually, you can Google it, spatial reasoning. There is a lot. You can print it out and you can do. Alright, okay. So, okay, the next one is reading and writing. This one is common that as long as you can read, so we suggest to do reading activity as it's help with cognitive learning, and this activity may direct enhance activities attention span. Okay, mostly for the elderly people, okay, they do less activity at home, so we can suggest doing the reading newspaper every morning and do it as a daily habit. Okay, next one for the social activities. Okay, we suggest to engage in social activity like doing volunteer work, spending time with friends and family, and children also need to spend time with their parents. Okay, to keep mind active by stimulating conversation and social cognition. Okay. Additional info, research published in Journal of Neurology found that seniors who engage in the social activity shows preserved cognitive function and can slower rate of the cognitive decline. Okay, this one is a board games. Okay, board game we have lots. For example, chess, Scrabble, mahjong, and many more. Okay, who don't like some people who don't like the computer games, you can try on this game. Okay, so this one enable player to think 4 strategies: think critically and solving problem. Okay, for the next one is the cognitive flexibility. Okay, this one is ability to shift thinking about 2 different concepts. Okay, if you see this image, there are some numbers and alphabet in this sheet. Okay, what you need to do is you need to connect the number and alphabet alternately. For example, okay, it begins with 1. Okay, then goes to A. After that goes to 2 until finish. So this is this activity you need to shift thinking between 2 different concepts. This is what we call the cognitive flexibility. It's one of the treatment that you can do. Okay, and this is frequently used for neuropsychological to detect the progressive cognitive impairment. Okay, and then the last one, creative art and craft activity. Okay, you can do the stitching activity and also craft activity. Like this one, we playing with the dough, and we use that as a magnet. Okay, you can use you can do other any craft activity like doing decorating vase, decorating something, coloring. Is up to you. Alright, and this creative activity act to promote and cultivate mindfulness, stimulating neuroplasticity of the brain and building cognitive reserve. Okay, there is one quote from Shaheen Lakan that say, make brain training a daily habit and build the mental reserve to delay the cognitive decline. So let us do brain activity as a daily habits to reserve our cognitive function. Okay, this one is a few more fun activities, so you can try all these. It can be any other than this, but this one is just for example. Okay, as long as it's safe for patient to do, then we encourage to do this activity. Okay, so that's all from me. Thank you. Okay.
Thank you, Mana Amira, for teaching us on the different types of cognitive training that we can do to keep our mind sharp and healthy. Next up, we have an equally interesting topic. Persons living with dementia may also suffer from behavioral and psychological issues, leading to a lot of caregiver stress and burnout. It is my pleasure to invite our very experienced senior geriatric nurse, Reda, to share on non-medication strategies in managing or caring for person living with dementia and BPSD. Nurse Reda, I hand over to you.
Okay. Thank you for the kind introduction, Dr. Erin. My name is Staff Nurse Muhammad Reda, Sahibi Abdul Ghafur. I work in 13U geriatric ward for 12 years. So today I would like to present about you non-pharmacological management for BPSD. So ini adalah keratan akhbar yang menunjukkan dia menunjukkan bahawa between 10 to 15% of the population will comprise people over 60 years old. So ini menunjukkan peningkatan daripada masa ke semasa. So dalam masa 2030 nanti kita akan melihat peningkatan yang semakin meningkatlah warga emas pada masa akan datang. Jadi kat sini kita nak introduce apa itu BPSD. BPSD adalah a range of neuropsychiatric disturbance such as agitation, aggression, and depression and apathy. This behavior can be extremely stressful for the person and their family and carer. Appropriate treatment for BPSD can significantly improve the quality of life of the patient. So BPSD adalah neuropsychiatric disturbance lah yang epidemiology. BPSD typically present in the later stage of dementia. 80 to 90% of people with dementia usually present with at least one BPSD symptom. The frequency of BPSD increase with the severity of dementia. So semakin severe dementia dia, so semakin keraplah BPSD itu akan meningkat. So jadi apa yang kita nak buat bila ahli keluarga kita, orang yang kita sayang ada BPSD ni. So hari ini kita akan tunjukkanlah management BPSD, apa yang kita kena buat lah. So tujuan, objektif untuk management untuk BPSD ini adalah untuk maximize the functional independence kita punya ahli keluarga tu. So kita nak bagi dia boleh buat semua sendiri, dia punya ADL, activity daily living dia tu. Kita nak improve dia punya quality of life. So kita nak kurangkan stres ahli keluarga kita. Sebab kita tahu untuk menjaga pesakit-pesakit ahli keluarga yang ada masalah dementia BPSD ni, dia sangat memerlukan, ada satu cabaran yang tinggi. Jadi kita nak kurangkan caregiver punya stres. So kita nak bagi tolong bantu ahli keluarga kita untuk cope with the behaviour of the patient with BPSD. So ini adalah contoh-contoh management yang kita boleh buat untuk pesakit-pesakit ataupun ahli keluarga yang mengalami BPSD. Contohnya music therapy, orientation therapy, physical activity mobility program, reminiscence therapy, massage and touch therapy, art therapy. So ini adalah untuk relative orientation therapy. Jadi kat sini kita kena terangkan setiap hari. Sekarang ni hari apa? Today what today is day? Dia punya hari, tarikh berapa, hari bulan, siang ke, malam ke, pukul berapa. Jadi kita kena bagi tahu dia. Hari-hari kita kena remind dia. Jangan pernah bosan bila dia kerap tanya hari ni hari apa. So kita just jawab je. So lagi kita boleh introduce dia pada music terapi. Apa perkara, apa muzik-muzik, apa lagu-lagu kesukaan dia, kita bagi dia dengar. Mungkin dia ada kenangan-kenangan masa lalu yang dia suka berkaitan dengan lagu-lagu tersebut. So kita boleh involvekan dia kepada ahli-ahli grup yang lain lah. Reminiscence terapi, kita boleh tunjukkan gambar-gambar lama dia, apa benda yang dia buat. Mungkin itu adalah kenangan-kenangan dia. And then massage terapi, kalau jika kita ada masa, kita boleh urut-urut dia. And then ini adalah art terapi, contoh-contoh yang kita pernah buat lah untuk pesakit-pesakitnya. Boleh tengok kat situ. Kita serlahkan bakat dia terhadap art terapi ni lah. Okay. And then kita involvekan dia, make sure kita sama ada kita hire kita punya fisioterapi datang ke rumah jika perlu, ataupun kita bawa dia ke taman untuk bawa pergi exercise apa semua. So kalau boleh, kalau patient pesakit-pesakit ahli keluarga yang masih boleh berjalan lagi, kita jangan bagi dia duduk kat rumah tanpa buat apa-apa. At least kita kena involvekan dia dengan physical activity at least. So supaya tak adalah nanti dia ada muscle atrophy apa semua berlaku. So dari segi communication, kita perlukan set a positive mood for the interaction. So cakap pun kena lemah lembut, jangan kasar, sabar dengan apa yang dia mahu. So kita perlu bila setiap kali bercakap tu, pastikan kita beri perhatian yang penuh lah untuk dia. So kurangkan distraction ataupun bising. Kalau bila nak bercakap dengan orang tua ni yang mempunyai masalah BPSD ni, kurangkan background bising lah. So kalau perlu, kita bawa dia kepada ruang ataupun bilik yang senyap. So kita boleh tahu apa masalah yang dia nak cakap. Mungkin dia ada sakit ke, ataupun dia nak pergi sana ke sini. Kadang-kadang dia cari barang-barang dia tak jumpa. So kita dengar dengan with ears, eyes and heart. So kita kena sabar dan bagi masa, bagi dia ruang, bagi dia masa untuk dia explain apa masalah dia. So jangan bila kita cakap dengan dia tu, kita potong apa yang dia cakap. So bila kita nak bertanya, kita ask short and simple question. So jangan bagi tanya ayat-ayat panjang-panjang. So contoh yang saya boleh bagi, tanya, pakcik dah makan ke belum? So mungkin dia akan cakap dah, sekejap lagi, ataupun kalau belum, mungkin sekejap lagi, macam tu. State the message clearly and sit face to face. Jangan bila kita bercakap dengan dia, tiba-tiba kita borak dengan kawan kita. So kita tak mahu macam tu. Use simple word. speak slowly. Cakap bila cakap certain word tu cakap sepatah-sepatah, jangan terlalu laju, cakap macam cakap dengan orang biasa. So talk about one thing at a time. Keep the conversation simple and direct. So untuk patient yang ada masalah sleep problem pula, kita limitkan daytime napping dia. So jangan kita daripada pagi tu lepas breakfast kita bagi dia terus tidur. So tak boleh macam tu. Kita kena bagi dia involve dengan aktiviti-aktiviti. Walaupun tak buat aktiviti fizikal, kita bagi duduk atas kerusi, tengok TV, tengok movie, tengok apa-apa yang dia suka, bawa dia pergi jalan-jalan, lepas tu exercise sikit, cycling yang tu. Okay. Setting ambient temperature, jangan terlampau sejuk ataupun jangan terlampau panas. Agak-agak dia punya ruang udara, ruang temperature tu dalam suhu bilik saja. So ensure quiet and calm environment lah. Kalau bila patient nak tidur tu pun ensure quiet, jangan terlampau bising. Kalau ada masalah dia tak suka yang terlampau silau, kita boleh dimkan light tu. And then sebelum tidur tu avoid heavy meals or caffeine. Sebab itu akan efek lah untuk masalah tidur dia nanti. And then untuk pesakit yang ada masalah hallucination pula, prevent argument. So jangan kita bila dia tengah hallucinate tu, jangan kita bergaduh pula dengan dia. Kita dengar dulu apa yang dia cakap, biar dia. So once dia dah settle down, kita comfort dia pula. And then kita distract dia with another topic or activity. Ensure ruang sekitar tu selamatlah, safe environment, so supaya dia tak ada access kepada anything yang harmful. So once bila ada patient yang ahli keluarga kita yang agitated ataupun agresif, perkara yang kita kena buat, stay calm, soothe, comfort and assist them. Kita tanya dia apa masalah dia sebenarnya, apa yang dia nak sebenarnya. So kita reduce distraction, divert dia punya attention pergi, contoh kalau dia tengah mengamuk-ngamuk tu, dia nak balik ke apa, kita divert dia, kita bawa dia pergi, okey kejap lagi anak akan datang pukul berapa, kita bagi tahu. So kita bawa dia pergi buat aktiviti lain, kita pergi tunggu sementara nak tunggu anak datang tu, kita bawa tengok movie, tengok cerita apa yang dia suka, tak pun ajak kita kenalkan dengan orang yang lain, kawan-kawan yang lain, pesakit-pesakit yang lain yang healthy jugalah. So ensure safe environment. So kita tak ada, make sure jangan ada barang-barang yang berbahaya lah, seperti pisau ke apa yang berdekatan dengan tu. So barang-barang yang bahaya tu kita kena lock. So perkara yang kita jangan buat bila kita handle dengan pesakit-pesakit ni, make sure kita jangan kita lawan balik apa yang dia cakap. So kita kena calm down, make sure kena calm down. And then jangan sesekali guna bahasa kasar. So itu yang akan menyebabkan dia lagi marah lah. Untuk pesakit depression pula, assure them regularly. Kita kena rasa cakap dengan dia, borak, sebab dia sebenarnya bila pesakit yang ada depression ni, dia perlukan attention. Dia nak someone berada dengan dia lebih. Jadi dia perlukan perhatian yang lebih. Jadi dia tadilah dia rasa sunyi. Kadang-kadang itu sebenarnya masalah. Dia nak kita ada orang dengan dia sebenarnya. So schedule activity, kita bawa family schedule activity dengan family member dia. Kita kena family ahli keluarga pun kena main peranan penting lah bila kita nak handle patient depression ni. So kalau kuat tu memang kita akan regularly buat video call dengan family member, especially dulu time during COVID, memang kita ada buat video call lah kalau lagi-lagi patient yang kena isolate. So continue with their hobbies and interests. So benda-benda yang dia suka tu kita memang galakkan dia buat, as long benda tu tak membahayakan pesakit. Untuk patient yang ada masalah BPSD dengan wandering ni, so kita tengok apa masalah sebenarnya dia nak kerap wandering ni. So mungkin dia dalam keadaan sakit, tak selesa, ataupun dia terlampau bosan, feeling lost, ataupun dia memang nak balik rumah sebab dia contoh sekarang dia berada kat kawasan hospital. Ini adalah unfamiliar tempat area yang dia, so jadi memang dia akan, jadi kita kena try comfort dia. So jangan lawan dia. Kita kalau pesakit yang contoh kalau ada kat ward tu, kita akan lockkan semua pintu, and then kalau kita dah access patient tu safe untuk jalan, kita akan biar dia jalan. Cuma make sure ada orang yang akan tengok dia lah apa yang dia nak buat, as long benda tu tak membahayakan dia. Kalau patient tu ada risk untuk jatuh, make sure kita letakkan dia dalam tempat area yang safe lah. Kita akan letak tilam atas lantai, biar dia nak buat apa dalam tu, biar dia nak buat apa. So make sure door, kalau kat rumah kita make sure pintu kena kunci, jangan bagi dia ada ruang untuk akses benda-benda yang berbahaya. And then termasuk bila ruang tempat ini jalan pun make sure tempat tu clear. Jangan ada barang-barang bersepah. Lagi-lagi kadang-kadang ada mainan kanak-kanak ke apa, takut dia bila terpijak jatuh, itu akan membahayakan pesakit itu sendirilah. Home safety and management, make sure pintu macam biasa saya cakap tadi, pintu kena sentiasa tutup. Ubat-ubat make sure kena label, antara pencuci pakaian, bleach apa semua duduk letak tempat yang selamat. Make sure jangan sampai dia ada akses. Sekarang sebab dia tak tahu itu benda tu apa. Ensure good lighting. Tempat yang biasa dia lalu tu, make sure tempat, contoh nak pergi tandas, tempat kena lampu tu kena cerah. Jangan terlampau malap ataupun terlampau terang sangat pun bahaya juga, sebab boleh silau. Ensure floor is clutter free. Kitchen safety, make sure ada automatic shut off stuff lah contohnya. And then fixing a bit curtain across the front door. Painting the door with some colour with wall. Contoh kalau yang saya boleh bagi, ada tangga tu sendiri pun kita kena ada bila dia ada nak untuk next step tu kena ada beza warna. So dia tahu ada lekuk kat situ. So kita dah explain kat dia. Ensure dia ada, kalau pesakit ni sebelum ni ada history, dia pernah keluar dari rumah tanpa diketahui. Jadi kita galakkan pesakit-pesakit ni pakaikan wristband. Ya, so yang ada identiti dia apa semua, ada alamat kita, rumah kita, nombor telefon kita. So in case kalau ada apa emergency, ada orang luar jumpa, so dia boleh call nombor dekat wristband dia tu. So inform kalau jenis komuniti kita yang prihatin tu, kita boleh inform jugalah tentang keadaan bapa kita, ahli keluarga kita, tentang masalah dia semua. So at least kalau benda-benda ni semua berlaku, kita ada komuniti yang akan bantu kita jugalah. So setiap penjaga, be the person who understand and can share the person's story. So caregiver, so kalau kat sini kita boleh bagi caregiver training. Make sure kalau ada masalah, inform kita. Kita akan ajar step by step apa benda yang kena buat. Kita juga boleh bagi pamphlet, ajar macam mana nak cope with individual with DBPSD, maintaining familiar environment with regular routine, organize an activity program. So kita ada boleh suggest untuk pergi Dementia Care Center. Contoh ada ADFM ataupun Johor Bahru Alzheimer Disease Support Johor Bahru. Kat situ boleh dapatkan lebih maklumat tentang cara penjagaan. Boleh tengok sendiri macam mana dorang aktiviti apa yang dorang buat setiap hari untuk pesakit. Dorang memang dah ada schedule kat situ. Okey, kalau ada burnout, ni ada contoh common sign of caregiver burnout. So kita akan sentiasa tengok marah, nampak penat, uninterested in things they used to enjoy, forgetful, foggy, cepat marah, anxious, hopeless. Kalau ada masalah, tolong bagi tahu. Jangan simpan seorang-seorang. Boleh inform doktor apa semua. So pada situ kita boleh arrange apa yang patut untuk ni. So mungkin kita bagi dia rehat dulu, jangan terlampau fokus ni. Okey, ini saya bagi contoh sikit lah untuk behavioral intervention technique. Behavioral intervention technique is a strategy that used to manage and reduce the challenging behavior in individual with dementia. So focus on understanding the triggers for the behaviors and addressing them proactively. So behavior intervention ni ada contoh dia lah, ABC, antecedent, behavior, consequence. So antecedent tu apa? So antecedent tu adalah perkara kita macam mana kita, apa yang kita nak identify what happened before benda yang berlaku. So B tu apa yang berlaku semasa lah, during, and the C is a consequence lah, after the challenging behavior. So use this information to modify the triggers or the response to prevent the reduced behavior. Sekejap lagi saya akan bagi contoh situation yang kita boleh guna pakailah untuk teknik ini. And then redirection. So gently guide the person attention away from distressing situation or talk. Engage them in the different activity or conversation. And then lastly, validation therapy. Acknowledge and validate the person feeling, even if their perception of reality is accurate. Avoid arguing or trying to correct mistaken belief. Time out or quiet time. Provide a calm, quiet space for the person to relax if they become overstimulated. This is not punishment but a way to reduce sensory output. So kalau dia contoh tengah mengamuk-ngamuk tu, kita tarik dia, kita bawa dia kat ruang kosong, bagi dia relax dulu, tenang. So jangan kita letakkan dia bersama-sama orang lain. So kita tak nak nanti dia mengamuk-ngamuk sampai di effect orang lain. Jadi kadang-kadang benda jadi chain. So ini ada contoh, saya bagi contoh lah situation. Mrs. Johnson, an 80 years old woman with moderate Alzheimer disease, become agitated. Di situation ni berlaku dekat nursing home. So antecedent dia tu kita tengok what happened before behavior. Waktu dia adalah pukul 4 petang, location dekat nursing home, and then staff shift change occurring during waktu tu lah. So memang waktu tu aktiviti semua orang tengah buat ni. So kita tengok tadi B tadi for behavior. So Mrs. apa yang tengah buat waktu tu? Mrs. Johnson visibly become agitated lah. Kita tengok dia memang tengah agitated tu. She repeatedly asked to go home. She attempts to open the main door and leave the facility. She may become verbally aggressive if stopped. So dari situ kita tengok behavior dia memang dia start agitated. Dia nak buka-buka pintu sendiri. Semua dia dah cakap benda-benda yang mengarut lah. So consequence apa yang staff member buat, kita prevent dia daripada leaving. Mrs. Johnson become more distressed and agitated. She may require medication to calm down. Other resident become upset by the commotion. Jadi daripada ABC tu dia apa yang kita nak buat? So analyze, bila kita analyze after observing this pattern for several days. Mungkin benda ni dah berlaku for several days. Jadi the care team realised that Mrs. Johnson behaviour coincide with the time she used to leave work. So pukul 4 tu memang dia nak buat. Contoh pada masa lalu, mungkin waktu dia kerja tu, pukul 4 tu adalah waktu balik dia. So jadi kadang-kadang bila patient BPSD ni, dia akan rasa diri dia waktu yang lama lah pada waktu yang lepas. Kadang-kadang dia tak ingat pun pada waktu yang sekarang ni. When she was younger, the increased activity during the shift, change and dimming light may be triggering this memory lah. So apa yang intervention yang kita boleh buat berdasarkan analisis ni? So proactive approach, engage Mrs. Johnson in a meaningful activity starting. So sebelum pukul 4 tu kita ajak dia buat something. Jangan bagi dia duduk sendiri. Help bagi dia, ajak dia bawa. Contoh kalau dekat nursing home tu mungkin untuk prepare light snack dululah untuk next group activity. And then environmental modification, reduce visible cost. And then accuse of people living by moving her to quieter area away from the main entrance during this time. Okay. And then next, validation and redirection. Kalau dia still become agitated, validate dia. I understand you want to go home. Okay. And gently redirect her attention. So before we go, could you help me with this? Could you help me with that? Ajak dia buat something. So kita faham dia nak balik rumah, tapi sebelum kita ajak dia, mungkin sebelum nak balik rumah tu, boleh tak tolong saya ni, ajak dia buat something. So okay. So bila dia rasa macam tu, okay lah, saya tolong dia dulu. So bila dia start tolong, kita dah buat something tu, dia mungkin dia dah lupa apa yang dia nak buat tadi. And then create a going home ritual. Develop a daily routine around 4 PM that mimics going home, such as walking to her room, changing into comfortable clothes, and settling with a favorite book or TV show. And then make sure last kali staff awareness, ensure staff member make sure kena aware this plan lah. So baru kita boleh sukses dengan dia punya plan. So by using ABC analysis this way, the care team can address the underlying triggers of Mrs. Johnson's behavior, potentially reducing her agitation and improving her quality life without resorting to medication as the first line intervention. Okay, that's all for today. So make sure bila kita menjaga orang tua ni, make sure kita kena sabar. Bila tak sabar, itulah jadi ada abuse of elderly. Sebab kita kena ingat, kita sendiri akan jadi tua pada masa akan datang. Mak bapak kita nak jaga, kita pun ada risiko untuk berjalan pada yang sama. Jadi penting sabar. Okay, thank you.
Thank you, Staff Nurse Reda, for sharing us the practical tips in managing persons living with dementia and the behavioral and psychological symptoms of dementia. We hope the sharing by Staff Nurse Reda just now can offer some help to the caregivers out there as you look after your loved ones with dementia. Our last topic of the day, last but not least, covers one of the most important aspects in ensuring well-being of our older adults, which is social support and social care. So we have today Mr. Yazil, our medical social worker at UMMC, to share on his role as a social worker in managing care of older persons. Mr. Yazil, I hand over to you.
Thank you for the introduction. Firstly, I would like to say thanks for the organizer for inviting me in this webinar. So I introduce myself first. I'm Muhammad Yazil bin Mahmud, medical social worker from PPUM. I am in charge of all the geriatric ward, including the patient from the clinic geriatric. I'm also in charge patient from the psychiatric ward, especially for male patient. Okay, today we will discuss regarding the what is role of the social worker in terms of to help patient geriatric or patient or the older patient. So my slide in English, but sometimes I will speak in Malay lah to make sure everybody understand what is I am trying to inform or trying to explain to audience. So mostly this is what is social worker do. This is what is the role of social worker in terms of to help older patient in the geriatric ward. First is biopsychosocial assessment. So I will go one by one after this. Okay, first biopsychosocial assessment to identify the support needed by the patient and family carer. The second one is financial assistance, is to coordinate the funding for equipment and the special drug, then to ensure that nursing care can be continued by carer as what being practiced in the ward. The third one is discharge planning, is provide guidance information for the discharge plan, discussion with family members, carer and the caretaker, and most important, an opportunity for mutual sharing and ventilation of feeling, opinion, issues and complaint. The next is counseling and emotional support, is assess psychological function of the patient and relative in the need of counseling or emotional support. The last one is resource and the guidance, especially for patient referred for carer or placement or financial support or social support. So ini merupakan 5 perkara utama yang social work lakukan di PPUM, especially to membantu pesakit-pesakit yang dirujuk di ward ataupun klinik geriatric. So kita pergi one by one untuk lebih faham apakah biopsycho assessment, apakah discharge planning, apakah bentuk-bentuk bantuan kewangan yang diberikan, dan juga apakah bentuk resource ataupun bentuk-bentuk guideline atau bimbingan yang diberikan kepada pesakit-pesakit warga emas. This is what is biopsychosocial assessment. So actually ini perkara yang paling penting dalam menentukan bantuan dan juga assessment kepada pesakit. Ini biopsychosocial assessment, kita tidak boleh melakukan kesilapan dalam biopsychosocial assessment kerana ia boleh menyebabkan kesilapan dalam pemberian bantuan. So social worker perlu berhati-hati dalam menentukan biopsychosocial assessment kerana ia akan menentukan apakah intervensi lanjut yang boleh dibuat untuk membantu pesakit-pesakit yang dirujuk. Ada beberapa isu, beberapa perkara yang perlu dilihat dalam biopsychosocial assessment. Yang pertama adalah tentang mental and emotional health, keadaan pesakit pada masa itu ketika dirujuk. Yang kedua, behavior, tingkah laku pesakit, dan cognitive abilities, sama ada pesakit aware tentang keadaan dia di ward ataupun aware tentang keadaan penyakit dan rawatan yang mungkin akan dijalankan semasa di ward. Juga yang penting bagi social worker adalah social background. This is very important, sebab kita perlu tahu apakah latar belakang pesakit dan apakah status pesakit, sama ada pesakit dari kategori bagaimana. Contohnya pekerjaan, status perkahwinan, dan juga dari segi pendidikan, dan juga segi hubungan antara keluarga dan support system. Penting bagi social worker menentukan pesakit dalam kategori mana. Dalam kategori bantuan kita ada kategori B40, kita ada M40, kita ada T20. So assessment ni penting untuk menentukan pesakit yang dirujuk dalam kategori mana supaya kita boleh tentukan intervensi yang bersesuaian yang diperlukan oleh pesakit. Seterusnya, living environment. Sometimes kita pergi melihat juga keadaan persekitaran di rumah apabila kes-kes yang memerlukan special needs, So yang seterusnya adalah financial situation serta medical history, medication and treatment plans. So medication sometimes kita kena tengok apakah yang dirujuk, ubat yang dirujuk pada masa ini adalah ubat yang sedang digunakan pada masa ini. So sometimes ada pertukaran ubat, sometimes ada isu default treatment yang menyebabkan pesakit perlu diarahkan ataupun diminta untuk membeli ubat-ubat yang lebih special daripada sebelumnya. So perkara ini juga kita pernah lihat supaya lebih teliti dalam memberikan bantuan kepada pesakit dan kita boleh bagi intervensi yang bersesuaian. Salah satu cara untuk meningkatkan ataupun menentukan penilaian psikososial dengan lebih tepat adalah home visit. Perkara ini penting juga, terutama bagi kes-kes yang kita tidak mendapat maklumat yang detail ataupun terperinci daripada pesakit ataupun ahli keluarga. Kadang-kadang kita just menggunakan dokumen sokongan and temu bual sebagai our assessment, but sometimes kita rasa something yang perlu kita go detail, then we have to do, the social worker have to do the home visit, melawat rumah pesakit untuk melihat keadaan sebenar, keadaan pesakit ataupun situasi sebenar ataupun status sebenar pesakit dari kategori mana. Yang pertama adalah bertujuan untuk assessment related to the financial issue. Kita nak melihat kalau dia tinggal di rumah, adakah rumah dalam kategori mana, rumah teres ataupun rumah kondo ataupun rumah apartmen, ataupun apakah kemudahan-kemudahan yang ada di dalam rumah tersebut, dan apakah support-support seperti harta benda yang lain seperti kereta dan sebagainya, adakah sama seperti yang dimaklumkan kepada social worker sebelum ini. So yang seterusnya, assessment of environmental hygiene and adequate space, and also kita melihat dynamic of relationship within the family member carrier. Kita nak melihat perhubungan di antara keluarga. Kadang-kadang tinggal serumah tapi no communication. So sometimes kita nampak ada isu kat sini, especially in term of caregiver. Ini yang kita takut, duduk serumah tapi janji boleh jaga, but actually patient is not the family is not really want to take care of the patient. So ini yang kita bimbang sekiranya ada perkara sebeginilah. So seterusnya, assessment about the equipment and prosthesis. If for example, if patient discharged for ventilator, we have to see all the things, especially for the safety issue lah. So before we decide sama ada bantu ataupun tidak, kita kena lihat sama ada persekitaran rumah, kelengkapan rumah, elektrik sebagainya mampu untuk menggunakan alat ventilator dan oxygen concentrator, for example. So ini perkara yang amat penting jugalah sebelum kita bantu patient in term of perkara tersebut. Assessment and identification of community support and resources available. Kita kena lihat di rumah pesakit tu ada tak bantuan-bantuan daripada komuniti yang berdekatan, sebagai contoh persatuan penduduk ataupun klinik kesihatan yang berdekatan, supaya ia akan lebih perancangan kita ataupun penilaian kita terhadap bantuan yang pesakit perlukan ini lebih detail, lebih tepat dan lebih boleh membantu pesakit pada jangka masa yang akan panjang. Yang kedua, ini perkara yang sering dirujuk kepada social work department lah, bantuan kewangan or financial assistance. Mostly 70% case referred to us is for the financial assistance, and nanti saya akan show what is financial assistance yang biasanya we have for our patient. So actually bantuan kewangan is bertujuan adalah untuk reduce financial burden to patient and family, of course, dan reduce psychosocial problem related to the finance. So the main aim is to elakkan daripada patient default treatment lah. Itu yang penting lah. That's why kita memberikan bantuan kewangan ini especially focus on default. Kita tak nak pesakit default, especially in the di klinik geriatrik. Kalau kita tidak bantu ubat pesakit, sometimes dia akan stop the medication dan ada isu-isu komplikasi yang lain, dan ini boleh menyebabkan keadaan pesakit bertambah lagi teruk daripada sebelumnya. Ini yang penting untuk saya inform kepada audience, jenis-jenis bantuan yang boleh kami ataupun pihak social work department berikan kepada our patient. Yang pertama adalah medication, ubat-ubatan. Ubat-ubatan hanya terhad kepada ubat special pulmonary, ubat khas. Is not for ubat standard pulmonary, kerana standard pulmonary biasanya ubat just few dollars, few ringgit sajalah. Ubat ini boleh diletakkan di dalam bil hospital ataupun diperolehi terlebih dahulu dan put in the hospital bill. But special pulmonary you have to pay first before treatment. So that's why kita hanya fokus kepada ubat-ubat special pulmonary, dan sometimes ubat-ubat ni memanglah harganya lebih expensive daripada ubat-ubat standard pulmonary. Yang kedua adalah equipment yang biasa dirujuk to my department is wheelchair, special wheelchair like lightweight reclining wheelchair, recliner wheelchair, or the what we call automatic wheelchair, ripple mattress, suction, hospital bed, commode dan sebagainya lah. So biasanya package lah for geriatric patient usually refer for the equipment package on this. This equipment usually patient need wheelchair, so additional for ripple mattress then hospital bed. So package dia akan melibatkan kos yang quite tinggi juga, maybe 2,000 until 4,000 ringgit. So yang seterusnya adalah keperluan nutrient support, keperluan nutrient support, keperluan susu khas yang mana pihak kami akan membantu pesakit-pesakit yang memerlukan bantuan. Nutrient diabetic, for example, nutrient fiber, for example. Cost of nutrient diabetic is RM84 per tin for 800 gram. So RM84 only can use until 2 days, 2 hari saja. Then after that have to buy the other one, the tin. So if calculate by monthly for nutrient diabetic, cost around 2,500 for 3,000 per one patient for patient. So that's why sometimes case referred to us for help for the nutrient diabetic or any susu khas yang lain. So lain-lain bantuan merujuk kepada angioplasty, implant, PICC dan sebagainya. Angioplasty biasanya dirujuk daripada ward kardio, tetapi ada juga yang dirujuk daripada kes-kes di ward geriatrik lah, but not many lah. But implant, PICC also not many. As in the geriatric ward, more case banyak kebanyakannya refer for the equipment, wheelchair dan juga susu khas. This is our tabung. I just nak inform about our fund is we call is PPUM Care. So kita ada dua kategori of financial assistance or bantuan kewangan. Tabung dalaman internal dengan tabung luaran. So PPM Care is tabung dalaman yang diwujudkan oleh pihak hospital, pengurusan hospital untuk membantu pesakit-pesakit yang dirujuk yang memerlukan bantuan kewangan seperti yang telah dijelaskan sebentar tadi. Okay, di bawah PPM Care we have also the other sub account yang mana kebanyakan akaun ini daripada organisasi luar seperti bank dan syarikat-syarikat luar. For example, kita ada UEM Fund, United Engineering Malaysia, tabung United Engineering Malaysia. Kita ada juga LZS, is Lembaga Zakat Selangor yang meletakkan duit setiap tahun di tabung PPM Care. For example, Zakat Selangor meletakkan hampir 250 hingga 300 ribu setahun based on demand from my department. Also UEM Fund akan meletakkan hampir almost 500,000 per year for our patient lah. So can use for the geriatric patient also. So stroke fund, dan kita juga ada eye care for patient geriatric yang ada isu-isu penglihatan mata, IOL dan sebagainya. YSD is Yayasan Sendavi, just focus for cardiac patient. ION, baru-baru ni we receive bantuan from ION 100,000 to help patient-patient yang referred for bantuan kewangan for pembelian ubat dan sebagainya. Also we have Agrobank dan juga Mr. DIY yang telah memberikan I think 2 tahun lepas RM300,000 kepada tabung PPUM Care untuk membantu pesakit di PPUM. So external kita ada tabung bantuan perubatan KKM, Lembaga Zakat Selangor juga kita ada, Makna JKM dan sebagainya. We have also bantuan from the more to the religious like Jita Asram, Seci Gujarati Association. So for PPM Care, bantuan akan lebih cepat because of we control the fund dan only our director of timbalan director yang akan approve. But for external fund memang usually can takes time to get the bantuan lah, especially from TBP, KKM or Makna sebagainya, takes time dan depends pada the permohonan dan documentation yang diberikan kepada mereka. Okay, that is the type of financial assistance lah. So for example, I just show the audience about the case we have bantu before. For example, Madam Eng has been diagnosed with stroke dan telah dirujuk untuk bantuan hospital bed, reclining wheelchair and repair mattress. We already approved 3,500 from the tabung PPM Care. Okay, Madam T also diagnosed as meningioma and requires special nutrition. Nutrient fiber cost seperti I mentioned tadi. Nutrient fiber dia adalah just 900 per month, but we bantu patient 750 per month. The balance is patient have to pay lah. So that one is based on between I and patient, between the assessment I with the patient and the relative. So if patient told is he just can pay 150, 200, we try, after the show documentation everything, so we agree. So that's why we come out with 900 per month times 6 months lah usually. So Mr. X is dementia patient, also need a placement of nursing home, is alone and no relative and no income. So the case referred to us to get the bantuan for nursing home, dan kita telah merujuk kes ini kepada Lembaga Zakat Selangor untuk bantuan pembiayaan nursing home dan approve sebanyak RM2,000 sebulan. This Zakat Selangor only agensi or institution yang membantu pesakit yang memerlukan pembiayaan di nursing home. So if referred to KKM, to JKM, dia orang tak ada fund for bantuan for nursing home, termasuk PPM Care. PPM Care also tidak boleh memberikan any bantuan kewangan, tidak dapat memberikan sejumlah bantuan kewangan untuk pembiayaan nursing home. So only di Malaysia ini bagi saya yang saya biasa berurusan adalah dengan Lembaga Zakat Selangor, dan mereka boleh memberikan bantuan especially kepada pesakit-pesakit yang perlu ditempatkan di nursing home because of family poor or patient itself is no relative, alone dan so on lah. So that's why for nursing home we have a bit limited if to get the bantuan for pembiayaan nursing home. So but if you stay in Selangor and Muslim, then easy. So they have fund as 2,000 maximum, I think 2,000 maximum, then can get until can go until 1 year. So the third one role is social worker role to manage an older patient is counselling and emotional support. So this is also important, basically to do the individual counselling and the family conference. Okay, di PPUM kebiasaannya kita hanya buat dua type of counselling. Yang pertama adalah individual counselling dan yang kedua adalah family conference. Kita belum ada kesempatan untuk menjalankan like a group therapy and support group activities. So kes-kes yang dirujuk biasanya berkaitan dengan stres yang dialami oleh patient dan caregiver in term of penjagaan dan kewangan especially. So kita memberikan counselling after rujukan daripada doktor, kita memberikan support, emotional support after rujukan daripada doktor, dan bukan saja kepada patient but also to caregiver, to penjaga yang mungkin mengalami masalah dalam proses penjagaan pesakit geriatrik di ward ataupun pesakit telah lama telah lama bedridden, so the caregiver or the family already depressed ataupun stress dalam penjagaan pesakit. So caregiver also kita berikan dari segi aspek sokongan emosi dan counselling. Purpose dia adalah seperti yang dimention di sini, purpose of counselling is to help individual through the temporary crisis, also to facilitate the adjustment, to help in adapting to the change or new environment, also to help individual to make wise choice. Sometimes perlu ada interaction between patient and social worker dalam proses untuk membuat keputusan, terutama dalam aspek penjagaan. So interaction we call is emotional support, or sometimes if we detail we call is counselling. This is emotional patient talk and fears. Biasanya kita nampak di ward inilah yang sering berlaku. Even dia duduk sorang-sorang, even dia stay alone in the bed, but sometimes dalam pemikiran patient ada pelbagai isu. So antaranya, will I become heavy burden to my children? I miss him so much, I feel I can't let him go. So yang biasa yang I selalu in charge is I really don't want to go to nursing home, but my son doesn't care of me. My son want me to go to nursing home. He has no time for me. That is selalu I nampak kes beginilah, because the son or the daughter bekerja, so tidak ada masa untuk menjaga pesakit sepenuh masa, dan plan to send patient to nursing home. But the problem is patient don't want to go to nursing home. Ini memerlukan banyak support, emosi support and counselling terhadap patient, maybe also discussion with the anak, make sure ada keputusan dibuat, otherwise dia akan drag patient in the ward, so no decision, so patient still cannot discharge. So itu yang kita tak nak. Alright. So the fourth one is discharge plan. Discharge plan is process aimed at coordinating the patient continuing care after discharge with the patient and others caregivers. Nampak senang, actually discharge plan paling susah dan paling tidak digemari oleh social worker apabila dirujuk kes begini. Very difficult sebab proses dia panjang. Kita ada banyak perkara yang perlu lihat in term of untuk membantu pesakit. It's a process and not isolated event. It should involve the development and implementation of plan to facilitate the transfer individual from hospital to appropriate setting, especially patient yang tidak ada keluarga yang perlu dihantar ke mana. That is satu perkara yang a bit difficult actually. The main concept is continuity healthcare. So why discharge plan important is like reduce length of hospital stay, improve quality of patient, increase patient family satisfaction and reduction in the number of unplanned hospital visit. Kini memang doktor memang usually the team of medical memang don't like this happen, so patient kerap masuk because of penjagaan yang bermasalah di rumah. That's why discharge plan itu paling important. So this is I show this is a four aspect of discharge plan. Role of MSW social worker in discharge plan. Yang pertama, discussion with patient and family about post discharge after care, post discharge care. So we akan discuss with family or the relative berkaitan siapa yang akan menjaga pesakit selepas discharge. Sometimes patient or family tidak tahu siapa yang nak jaga, sama ada dia nak jaga sendiri or send to nursing home ataupun appoint the caregiver, means yang berbayar, or appoint the care center or the people yang datang ke rumah untuk memberikan servis penjagaan. So sometimes kita ada isu dekat sini untuk membuat keputusan, patient ada isu untuk membuat keputusan. So peranan social worker, kita akan berbincang dengan keluarga untuk melihat benefit or any problem in case patient stay in nursing home or take care by family. So discussion berkaitan dengan ni paling penting, sebab sometimes patient family macam I mentioned just now lah, patient don't want to go but family want to send to nursing home. That the issue. So ada drag kat situ nanti. So nursing home option, explore nursing home option based on the family budget. So sometimes family boleh hantar ke nursing home, ada kemampuan, tapi kemampuan tu ada limitation. Sometimes people, patient family call me, Yazil, I just can afford to pay around 1,200, 1,400, but I call all the nursing home, the charge is 2,500 above. So how I can mampu to pay for this nursing home? So I akan bagi the list of budget patient yang nursing home yang memberikan what we call, yang meletakkan cost 1,000 to 1,500. Sometimes I discuss with the nursing home tersebut. For my patient, actually patient also cannot afford, background B40 family, can you give a discount to my patient? Sometimes I discuss with nursing home lah, especially for the cost. So patient background to means that to gather information about the patient, especially patient yang datang ke ward yang admit without any identification. Some of our patient admit without any identification like IC or license memandu. So how to trace this type of patient? Sometimes we don't know is Malay or foreigner. So how to trace? That is the role of social worker to trace the social background or patient background. So usually kalau pesakit tu ada IC tetapi dia tidak dapat mengingati any contact number to the family members or rakan terdekat, ini senang sikit. Biasanya saya akan dapatkan IC pesakit, dapatkan IC or nombor IC pesakit, then I akan inform GPN about this case. So GPN biasanya dalam one day dia akan bagi information, okay, patient is this one, family is isteri dekat sini, nombor telefon isteri di sini, or anak ada 3-4 orang, this is number anak yang akan diberikan kepada saya untuk saya contact. Itu kalau ada IC. So just dapat nombor IC, I akan inform GPN akan bagi all information about the patient contact. So then biasanya kita akan call dan kita dapat information lah. But sometimes kita call tak dapat because of the relative tukar nombor handphone without inform the GPN. So GPN don't have any the current number or the new number of the relative. Itu yang kita bimbang. So kalau tak ada, a bit difficult. So if patient no IC, and zero, anything tak ada, apa-apa pun tak ada, so kita ada cara adanya ambil cap jari. I have to go to ward to take all the cap jari, and I have to email to GPN to ask for the pengesanan background patient, ataupun kita hantar all the cap jari to GPN yang berdekatan. Untuk cepat kita email lah, but sometimes email cannot trace all the things dengan correct, dengan teliti. So we go to GPN KL or any yang berdekatan untuk dapatkan untuk serah the cap jari dan dapat the maklumat berkaitan dengan patient. But takes time. If patient no IC or tak ingat IC memang susah. Kena ambil masa untuk trace. Sometimes tak ada dalam record. If tak ada dalam record, it mean patient is non warga negara Malaysia lah, non citizenship. Okay, the seterusnya adalah assistant for patient without relative. Some patient admit because of homeless. Sometimes geri patient also ada homeless, tak ada rumah. Especially sebelum ni tinggal secara tak menentu, vagabond sebagainya. So kita have to cari any NGO nursing home untuk hantar mereka. Ini yang menjadi masalah. Bukan semua orang terima patient secara percuma. But I have 2 or 3 contact. Sometimes I boleh dapat lah. But sometimes very difficult because of full. But we try also to pujuk the nursing home untuk terima my patient, especially patient yang memang homeless or geriatric patient yang memang homeless. So we will send patient by ambulance to nursing home. Okay, that is rule lah. So patient we cannot ask the nursing home to to discharge patient, ambil patient and bawa ke nursing home. We will send lah because of we ask for free. So the last one is resource and guidance. Ini yang selalu dirujuk kepada saya lah, especially for OQ card, geriatric. What also memang famous to refer to me about the OQ and the sara hidup. Orang kurang upaya card and the sara hidup. Why this is very important? Because if you have OQ card, anything in the hospital is free. So you don't need to pay the bill hospital and the what you call the cost of jumpa doctor, everything so free. So usually patient if geriatric dia memang try to aim to get the OQ card lah. So now JKM quite open. So you to submit the OQ card only can do by email. So if family, if patient have family, we suggest whether submit by email or submit to JKM yang nearest JKM. If family don't have time, try submit by email first. Then please follow up with JKM whether the application received or not. But if patient no relative like vagabond, just the homeless sebagainya, or patient is stay in nursing home, no relative run away from the family, everything, so I will help patient to apply for OQ card lah. Usually I ask the consultant or clinical for fill up the OQ form, then I will ask patient to give the IC, then I will take the photo of patient, then email to the JKM to get the OQ card. Then I will inform the JKM officer lah, to especially in Petaling, because very easy, then very it's not too bureaucracy to get the OQ card lah. Then but important is the sign or the fill up by the doctor or pakar. That very important. Then the other things is I will settle if patient very I mean patient poor or patient no relative or no caregiver. So the others is zakat institution financial support, because you can get bantuan from zakat like monthly also 400 600 a month for patient poor. So also we have sometimes bantuan from sewa rumah, everything. So ini kita boleh rujuk, kita akan inform patient, please go to zakat and they ask for the bantuan-bantuan berikut. Sometimes patient family ada kemampuan untuk membuat permohonan, so dia tak tahu where to go. So social worker akan bagi information regarding this lah. Kalau financial support for OQ, go to JKM. Kalau bantuan-bantuan lain, maybe can, if Muslim can go to the zakat. Kalau Chinese, maybe can go to Sechi to ask for any help regarding for the medication or anything. Alright, so the others is carer and placement, social support. Also sometimes patient ask for the information about any community to support patient. Sometimes patient boring at dekat rumah, so need activity to do with the others, colleague, everything. So you just give lah all the information. Same like emotional support, counselor, religious body dan sebagainya. So this is berkaitan dengan resource and guidance, but mostly case memang refer for OQ and sara hidup. So biasanya saya akan bantu pesakit lah to get OQ, especially patient yang memang poor, yang tak ada keluarga sebagainya lah. So sometimes ada keluarga, tapi keluarga pun sometimes blur, don't know how to go, pergi then tak sampai, then bawa balik form. So then I kata tak apalah, you just leave it to me, then I settle, I email to you, I email to JKM, then I contact the JKM. Paling senang macam tu lah. Otherwise kan 3 bulan, actually 1 month can get, sometimes because of this issue 3 month 4 month tak settle for OQ card. So yang ruginya patient lah, have to pay for the hospital bill, everything lah. So this is my plan for future. So I'm trying to get the financial assistance for the nursing home actually. So PPMK maybe next time maybe can help a little bit patient who really needs bantuan for nursing home. But now tak boleh. But I try to get. So I have to do the paperwork actually to present the management to open the bantuan for pembiayaan nursing home lah. So the others is trying to do the pusat aktiviti warga emas bersama ward geriatric and the clinical geriatric and somewhere area PJ or any nearest, because of kita perlukan something yang different sikit daripada yang lain. Maybe under PPM or under UM also can do later lah. But next week I will discuss with MPPJ to see whether can suggest on this matter or not. So PPMK is our fund actually. So we have many activity right now. So this is fund yang di-run by PPM social worker. So paling penting adalah untuk mendapatkan dana-dana. So I hope from the presentation people audience di luar mungkin boleh membuat sumbangan kepada PPMK, dan kita juga baru next 2 week kita akan ada aktiviti konsert yang bersama dengan Kai Bahar, Mawi, Hafiz Hamidun dan Lintim dan Rabani di Plaza Alam Central untuk untuk promo the PPMK and get the funding from the others or society from yang menghadiri konsert tersebut lah. So kita telah mendapat satu kerjasama baik daripada company penganjur, dan kita akan buka booths dan juga kita akan present our PPMK to the audience yang akan hadir di concert lah. Alright, so I think that's all from my side. Hopefully audience can understand what we trying to do to help to help the patient, especially from the geriatric ward and from the clinic. Thank you. All right.
Thank you, Mr. Yazil, for your active ongoing work in the social care of our geriatric patients and for sharing with us the various social support services for our patients at UMMC. So thank you, Mr. Yazil. So we have come to the end of our webinar today. Thank you everyone for staying all the way up to the end with us. I would like to say a big thank you to all the viewers there for being with us, and we hope that you have learned a lot from our esteemed speakers today. A big thank you to our esteemed speakers as well for spending your day with us and sharing your knowledge and information. On behalf of the organizers, if there are any shortcomings, we humbly apologize. Thank you again for being part of our webinar. See you and take care.